background. There we go.
Welcome back, or if you're new here, welcome. It's Nurse Jenny here from Nurse Life Academy, and I will be reviewing gastrointestinal questions and concepts that you must know for the CCRN exam. I will time mark this video, so feel free to just scroll through at your own pace, but I do give extra information and explanations after every question. I would greatly appreciate if you like and subscribe to my video if you found it helpful, also so that you can be notified of other videos that are dropping. Without further ado, let's get into the
really
GI
low on
content.
and I have it turned all the way up.
Question number 1.
Oh, it's probably because
there we go. In the setting of liver failure, except A, jaundice may be present in both acute and chronic liver failure. B, the development of hepatic renal syndrome is related to high mortality. C,
pausing. The following answers are true in the setting of liver failure, except true. Let's see. Is A false? Isn't it only an acute liver failure? Well, I guess you could have chronic liver failure and be a little jaundiced.
I mean, think about like your cirrhotics that are just like they come in and they're really jaundiced.
I don't know if alcohol is the leading cause of acute liver failure, is it? Or is it fatty liver?
For some reason, I want to say Tylenol, but I mean, we don't see it that much. But I feel like alcohol is more common.
B and C are true. B and C are true.
I was like, B seems to make sense to me. I was like, C is definitely true.
Yep. So lactulose, guys, pulls ammonia from the body. You get diarrhea.
A is very wishy-washy, which makes me think that that's true because it's not like it's an always or never. Like it was like it's always present, and it'd be like, okay, that's definitely not the answer. But it's like it's saying it may be present, and I'm like, I feel like that's true. Like
so I think D's incorrect. So we're going with D for incorrect.
Yeah, for some reason I want to agree.
I don't believe it's alcohol. I believe maybe fatty liver.
Lactulose is used to treat hepatic encephalopathy.
Or like you were saying, Tylenol.
Or D, alcohol abuse is the leading cause of acute liver failure. And the answer here is...
There you go.
D, alcohol abuse is the leading cause of acute liver failure. This is because alcohol abuse is the leading cause of chronic liver failure, but the leading cause of acute liver failure is acetaminophen. And all of the other answer choices are true.
Listen.
It said acute. We didn't even pay attention to the acute.
I wasn't even thinking about that. But somewhere in my brain it remembered.
What did it remember?
That it was Tylenol.
Oh.
But I was like,
because people use a lot of Tylenol.
So let's talk a little bit about the liver and what.
Hey, Shinyu. All right, here we go.
It does. The liver filters medications and it filters toxins. Most significantly, it filters ammonia, or NH3. It also synthesizes plasma proteins, which make albumin and coagulation factors such as prothrombin, fibrinogen, and other clotting factors. Now, acute hepatic failure is characterized by the inflammation of the liver, hepatic necrosis with significant destruction of hepatic cells, encephalopathy due to ammonia accumulation, and jaundice due to increased bilirubin. It's important to know that in acute hepatic failure, there is no portal hypertension present. In chronic failure, there is portal hypertension, and that comes from the liver scarring, which impedes filtering. Now let's talk specifically about acute hepatic failure. The most common cause of acute hepatic failure is acetaminophen overdose. And whether or not it's an intentional overdose or it's an unintentional overdose, Sometimes that can happen in chronic supratherapeutic acetaminophen use. It can certainly cause hepatic problems either way. Other causes of acute hepatic failure can be viral in nature. They can include acute hepatitis, autoimmune hepatitis, or they can be toxin-induced. Any of these causes, but specifically acetaminophen overdose, can lead to fulminant hepatitis, and that simply means that it is severe and sudden in onset. And in severe hepatitis, you will see rapid progression over hours or days to severe destruction of hepatocytes and severe encephalopathy. In reviewing the labs for hepatic failure, our ammonia level is going to be elevated. And the ammonia level tells you how well the liver is filtering. And in liver failure, it's not doing a good job, so that ammonia is going to build up. Your liver enzymes, AST, ALT will be elevated, and our PT-INR and PTT will be elevated, because remember that the liver makes coagulation factors. But when it isn't working properly, it can't make the prothrombin, the fibrinogen, and those other clotting factors. Also, the liver can't properly release bilirubin in the form of bile when it's injured, and that leads to a backup of bilirubin in the body. And that's where you see your jaundice come from. Just a little side note, but scleral jaundice is one of the first places that you will see jaundice visibly.
In the eyes.
Now let's look at our lab values that trend downwards. So hepatic failure will certainly result in low levels of albumin, since the liver isn't producing enough plasma proteins which make that albumin. And that's why these patients have such bad third spacing and ascites. Their body is hypoalbuminemic, so it does not keep fluid in those vessels. Additionally, platelets and fibrinogen will be low due to the lack of clotting factors we just talked about, and also your glucose will be low because the liver plays a role in gluconeogenesis, or making that glucose. The treatment for acute hepatic failure, well, if the cause is acetaminophen overdose, you will administer Mucomyst or N-acetylcysteine.
That's what I was going to say.
You will certainly want to decrease ammonia levels by administering lactulose or decreasing protein intake if they are encephalopathic. And since the liver has a large part in medication filtration, providers may need to adjust medication doses to appropriate levels. And as a nurse, just being careful when we're administering benzodiazepines, since these patients can't exactly filter benzos very well. So if they're already encephalopathic and you give them benzos, they might be zonked for a long time. You also may need to administer clotting factors if the patient needs them, because remember, they're lacking those platelets and fibrinogen, and their PT-INR and PTT will be elevated. Last but not least, if their hepatic failure is fulminant or if it's severe in nature, they may even need a liver transplant. Question number 2. Which of the following statements is correct regarding nutritional therapy? A. Parenteral nutrition is preferred over enteral nutrition. B. Hold tube feeding if diarrhea develops. C. Assess the placement of the feeding tube by inflating air and auscultating. D. Avoid bolus feedings in patients who are at high risk for aspiration.
Oh shit, my bad. Almost, oof. Which of the I'm not gonna lie, I was still thinking about missing that appointment. Which of the following statements is correct regarding nutritional therapy? Parenteral nutrition is preferred over enteral nutrition. That is not accurate. Hold tube feeding if diarrhea develops. I mean, technically the majority of our people who have tube feeds have diarrhea, so I don't think that's a problem. They look at electrolytes. If it's refeeding syndrome, then they'll change the rate. Assess the placement of feeding tube by inflating air and auscultating. I mean, you can assess. I mean, that is an assessment tool, but that's not, I'm not gonna... I'm still going to verify with a chest x-ray. I don't know if that's going to count as interesting. See, this is how I overthink things. C is questionable. I mean, I would do that, but I'm still going to get a chest x-ray or a KUB, either or, honestly. Usually I can see either. Avoid bolus feedings in a patient who are high risk for aspiration. True.
Are they talking about an NG tube or a Dobhoff, or are they talking about like a peg tube? Because
I
that'd be
think they're
different.
talking about exactly. That's where I'm a little that's why I'm like, it's saying placement of feeding tube. I mean, feeding tube, that could be a small bowel feeding tube, that could be a NG tube, that could be a peg tube, a GJ tube.
Because like you wouldn't do that with like a peg tube.
Well, A is definitely wrong. I wouldn't do
agree.
bolus feedings for risk for aspiration, so I want to say that's true.
That's what I was thinking as well.
D. I'm not going to hold tube feeding if diarrhea develops. That's to be expected, so I'm going to say D.
I agree.
Okay.
And the answer here is D. Avoid bolus feedings in patients who are at high risk for aspiration.
So parenteral, guys, is IV form, and if we can get someone to eat enteral nutrition, which just means through the stomach, it doesn't necessarily mean it has to be oral, it just means through a tube, through whatever, that route they prefer it. Parenteral is like a last-ditch effort if they're not able to tolerate tube feeds or whatever, and we have to get some form of nutrition, we'll do IV like TPN.
See, we call it parenteral and enteral.
You guys do?
Yeah.
Yeah. Different pronunciations depending on where you're at.
Yeah, like tomato, tomato.
Tomato, tomato.
Potato,
Potato, potato. But, like I was saying, like diarrhea tends to happen a lot with tube feeds. It's almost a guarantee. Same with like lactulose. A lot of people hold lactulose because they're like, oh, the patient has consistent diarrhea. I'm like, yeah, that's kind of the point. You don't hold lactulose for diarrhea. You're trying to get out pneumonia levels, and you're like, if you don't give it, they're just going to keep going up. You might want to not care about that as much.
Yeah. You're titrating to 3 bowel movements per day is usually the goal, or to mental status if you really need to go higher.
Yeah. And then like refeeding syndrome would be the only time that you would change your tube feeds rate or whatever even. Because some people just need gradual, and you'll just see a shift in electrolytes if that's the case. If it gets to be a little like insane where you're constantly like replenishing every single electrolyte because they're just dumping, then you just kind of gradually increase and do trickles first.
Nutritional therapy is used for patients who are unable to maintain adequate nutritional intake, and this can be for a variety of reasons. Enteral nutrition, meaning nutrition going into the stomach, is preferred over parenteral nutrition, which goes into the vein. That would be like your TPN or your PPN. And the reason for this is that enteral nutrition is associated with fewer complications, but it also maintains gut function and gut anabolism, which you would lose if you did parenteral nutrition. It's also less costly. For the CCRN, it's important to know the latest evidence-based practice literature, which I've listed here. So you want to make sure that you're maintaining the head of bed of at least 30 degrees, generally 30 to 45.
Yeah, another thing, if you are giving enteral feeds through tube feeds and whatnot, especially on your intubated patients, head of bed at 30. If you're lying flat, hold the tube feeds, or you're high risk of aspiration of lying them flat. You want to be very careful. That's the first thing you do before you lay them down to turn them or clean them.
You want to obtain radiographic confirmation of tube placement, so that means you're getting a chest x-ray to confirm your tube.
Not oscillatory. See, they'll only do that in certain circumstances just to make sure that they don't need to replace, so they don't waste the time of the person who's coming up to do the scan. So oscillatory, which is what I was saying before, I said that wouldn't be a definitive. I'd always get an KUB or x-ray like prior to, but I would use oscillatory just to make sure it is positioned. If I couldn't hear it in the stomach at all, I'm pulling back and reinserting before I even put in the order.
Want to inflate air and auscultate, that is not evidence-based practice. You want to mark the tube's exit site from the nose or the mouth with an indelible marker, meaning that it won't wash away. You want to avoid bolus tube feedings in patients who are at high risk for aspiration. Instead, put them on a slower rate, but a continuous feeding. You do not want to hold tube feeding if diarrhea develops, and you do not add dye to enteral feedings. Question number 3. You are taking
care of a patient who is admitted after an MVC, that's a motor vehicle crash. Your patient states that his airbag went off and he felt his seatbelt forcefully restrain his body in his seat. He has multiple bruises and abrasions all over. His main complaint is a sharp left shoulder pain at rest. Which of the following may be the cause? Pulmonary contusion, rotator cuff injury, fractured left scapula, ruptured spleen. I mean, he said it would be his left shoulder. Would it be rotator cuff? Fractured scapula. I don't think you'd have that from an accident. Sketch.
I've seen it before. You
Really?
could have all of these.
You could.
Yeah.
I mean, you could, but I'm going with what he was saying. He's got multiple bruises and abrasions all over, and the main thing he's complaining is of a sharp left shoulder pain at rest.
I think I know.
So is
what
it B
they're
or
getting
C? What?
at. Also, you're in the way of the answers, actually.
Oh, so oh.
Why don't you just move yourself to the other side?
Wait, are ER doctors the same as ER doctors in fan fiction? Wait, what do you mean, Hawk?
Yes, we're extremely good looking and very fit.
What did you say, Skitch?
I said we are extremely good looking and very fit. So yes. It's, that's I'm sure what it's like in fan fiction.
He said ah. That's all he gave you. He gave you ah.
That's
There you go,
okay.
Skitch.
That's all I need.
You just need an ah.
Yeah.
I can't go to the other side because look, my fucking thing over here is showing. Hold on, wait. I'll fix that. I'll go to the center. Give me just a second.
I was gonna say, Ashley, that seems like a you problem.
All right, let me try to fix this. God damn it, this is a pain in my ass. Like, it looks so lopsided in here. I got like my green screen at a catty corner angle, so.
It's fine.
Yeah.
It's fine.
All right, now you can see. You happy, Sketch?
Yes. I believe I know the answer. It's spleen.
Explain to me spleen, because I don't really deal with MVCs. Like, that's not... When we get them in ICU, we already know what's wrong with them. So you tell me. Come on,
So
ER man.
The spleen is in the left upper quadrant.
Yes. Well, isn't it
And-
partially? Because the head depends on if you're talking about the head or the tail, right?
Are you thinking about the pancreas?
Doesn't a spleen have like a... Never mind. Ignore me. You're right, I'm thinking pancreas.
Yeah, this
Continue.
Like a moon shape. Yeah.
Ignore me, Sketch! Go!
So, the liver is the most commonly injured organ in blunt abdominal trauma, but spleen is another very common organ injured in blunt abdominal trauma. And I think what they're getting at is they have a seatbelt sign, which basically means
Right.
that they had a lot of acceleration in the accident. So
Right.
that seatbelt actually causes trauma
Yep.
because it puts a lot of pressure on the abdominal contents. And
Right.
then you have shoulder pain because your diaphragm is innervated by your phrenic nerve, which comes from your cervical spine. And so that also innervates the shoulder. So you get referred pain to the shoulder from diaphragm irritation, which is the same reason why that when you have gallbladder pain,
Mm-hmm.
you sometimes have right shoulder pain. Because the gallbladder is on the right side. If it irritates the diaphragm on the right side, it irritates the right shoulder. And also, if you get free air, you might get shoulder pain, which is never a good thing in the abdomen if you have free air, because then you perforated a hollow viscus. So,
Yeah, we've had a lot of free air in abdomens several times over, so yikes.
so
Those were
I'm
perfed
pretty
though.
sure that's what they're getting at. Because pulmonary confusion, I mean,
Yeah, I didn't think
sure,
it was that.
like you could get that, and I mean
You could, but I don't think it was that.
But I think based off of what they're giving you, the answer they're looking for is ruptured spleen.
Okay.
Care of a patient who is admitted after an
You
MVC.
could
Wolf.
Main
also have a
complaint
fracture
is
of
sharp
scapula,
left, a pulmonary
but
contusion,
I think you would
fracture
probably
of
have
left
less pain
scapula,
at rest.
or
And
D,
same thing
a
with a
ruptured
rotator cuff
spleen.
injury, you'd have less pain at rest, and they're telling you you have pain at rest.
Ah, that's fair. I guess
And
paying
the
attention to
answer
that
here
comment
is
makes sense.
D,
This
a
is
ruptured
definitely a choose the
spleen.
best answer, but
So
I'm
it
like,
looks like this patient was in a motor vehicle
this
accident
is like a
and he
read my
potentially
mind kind of
sustained
question.
internal
You were
gastrointestinal
right.
trauma and from a ruptured spleen.
So I don't
Okay,
like this question.
let me go back to this. Let's see.
So this shoulder pain is actually
'Cause-
referred pain from a
So,
ruptured
like you were saying,
spleen.
referred pain.
Even the way
So
they
what we
phrase it
just
doesn't
went through
make
in the
sense.
last
They
question,
say, which of the following may be injured, not which is the most likely to be injured based off of this information.
Yeah, the verbiage sucks.
is described as Kerr's sign.
I would like to think.
And I know that there are
Kerr's sign.
so
Like the
many
computer
signs, so that's
manager.
why I have all these weird little ways of remembering everything. But for me, Kerr, K-E-H-R, has 4 letters,
I don't know
and
that anyone has ever
left
made a
has
diagnosis
4
on
letters,
absent
and they
vowel
both have
sounds.
E's in them. I know it's a tiny detail, but just remember that Kerr's sign
Like, even if you're
results
worried
in
about
left shoulder pain due to this
bilious or SVI,
diaphragmatic
like,
irritation, which most
an
commonly
X-ray,
is a
get a
result of a
CT.
ruptured spleen. And so this pain is actually a referred pain. And that means that it occurs when you have an injury in one area of your body, but you feel pain in a different area. And that happens because all of the nerves in your body are part of this huge connected network. And so in the case of a ruptured spleen and diaphragm irritation, that pain travels upward to the left shoulder. Some other signs you want to look out for a ruptured spleen include absent bowel sounds and abdominal distension. And if for any reason you hear bowel sounds in the chest, that means that you have a ruptured diaphragm on your hands and your abdominal organs have moved upwards into your chest, which is not good. This will lead to respiratory failure and extremely quick deterioration. So, big takeaway here is that Kerr's sign is left shoulder pain, and this is from diaphragm irritation, most likely due to a ruptured spleen. Question number 4.
Here we go. Fluid and electrolyte balance require close monitoring for a patient with an acute pancreatitis due to which of the following? Increased diuresis secondary to pancreatic enzyme release.
Shark.
Increased incidence of hypercalcemia. Increased capillary permeability resulting in fluid loss from the vascular space. and hypoglycemia due to pancreatic cell destruction. I mean, fluid and electrolyte due to which of the following? I'm between the C and D, because hypoglycemia
It's okay.
we see a lot in our pancreatitis. Pancreatic enzyme release, that also I know with our pancreatitis people, we tend to like give them lots of fluid. But I can't remember what the reason is for that. Sketch.
I believe it's C, because I think you get hypocalcemia, not hyper.
Yeah. I mean, that makes sense because we're talking about fluid, and that's my main thing is they talk about fluid loss. We're always doing fluid resuscitation in acute pancreatitis.
And then diuresis doesn't make sense, and
Yeah, because that
hypoglycemia doesn't have anything to do with the electrolytes.
Yeah, that was the only thing that my I guess it has nothing to do with the question.
Fluid and electrolyte balance require close monitoring for a patient with acute pancreatitis.
I hate
due to
distractions.
which of the following? Is
What's
it
up,
A,
Ken?
increased diuresis secondary to pancreatic enzyme
Sorry for
release,
leaving without
B,
saying anything. Is it okay if
increased
I lurk and
incidence of
support?
hypocalcemia,
Absolutely. Come
C,
lurk.
increased capillary permeability
Glad to see
resulting
ya.
in fluid loss from the vascular
I'm
space,
lurking in
or
spirit.
D, hypoglycemia due to
Your boy
pancreatic
Taj
cell
gotta be. I
destruction.
watched House. What's up, Taj? So we're going with fluid
And
resuscitation.
the
So
answer here
capillary
is
permeability.
C.
It was it.
Increased capillary permeability resulting in fluid loss
Apparently
from the
Taj did not
vascular
watch enough
space. So
Damn.
acute pancreatitis triggers a systemic
That's
inflammatory
okay, though. There's
response,
still time.
which results in the release of inflammatory mediators. And this leads to increased vascular permeability, or this capillary leak, which results in fluid loss from the vascular space and vasodilation. So it's important to monitor fluid and electrolyte balance in these patients because these massive fluid shifts may result in hypovolemic shock. The pancreas is composed of a head, a body, and a tail, and it kind of lies from the right middle part of the body to the left. And it has an endocrine gland which secretes insulin and glucagon, and it also has an exocrine gland which releases digestive enzymes, and it secretes bicarbonate to neutralize stomach acid. Now, in acute pancreatitis, there's this diffuse inflammation, there's destruction and autodigestion of the pancreas because digestive enzymes are activated prior to the release from the pancreas. So those digestive enzymes are just sitting there. They're just digesting the pancreas away because something activated those enzymes early. And when the pancreas starts auto-digesting itself, the body is like, what in the world is going on? This is not right. So it triggers a systemic inflammatory response, also known as SIRS. And just like we talked about, it releases inflammatory mediators. It increases vascular permeability, or this capillary leak, which results in fluid loss from the vascular space. And you also have vasodilation. But we have to ask ourselves, what happens in the body that those enzymes get activated early and they end up self-destructing that pancreas? Why would the pancreas betray itself like that? Well, most of the time, it's due to an obstruction of the pancreatic duct,
Taj.
which doesn't allow those digestive enzymes to flow through it. So these activated enzymes get stuck in the pancreas and they begin auto-digesting that pancreas instead of flowing through and digesting in the duodenum as intended. And the two main causes of this pancreatic duct obstruction are ETOH use or alcohol use and gallstones. Some other causes of acute pancreatitis can be abdominal surgeries, drugs, trauma, or infection, but the two big ones are going to be your ETOH use and your gallstones. Question number 5. Management of acute pancreatitis includes...
Boom.
What?
What?
This... I don't understand. What is a closed lung assessment?
Close lung assessment for all patients. I don't know.
To me, that's the only one that would potentially make sense, but I don't understand why. I'm like, you don't give antibiotics to all patients, you don't give all patients an NG tube, you don't avoid narcotics for all patients. So I have no idea why you would do a closed lung assessment, but that's
Yeah.
the only one that I'm like, maybe?
That's why. Is it just because of the Sears response?
I don't know.
All right, let's find
Are
out.
we
That's
right?
weird.
Which of the following?
Am I right?
A.
Is that the right answer?
Antibiotics
Hold on,
for
we're
all patients.
letting it.
B. C. A nasogastric tube for all patients.
Let it go
Or
faster,
D.
Ashley. I
Avoiding
don't have time for
narcotics
this.
for all patients.
I'm a very busy
Jesus.
man. Very
Shush,
busy.
Skitch.
The answer here
busy
is
Tosh.
B. A close lung assessment for all patients. So let's keep the conversation going about acute pancreatitis.
JC Boat said it's because
What is a
it's close to
patient
your
who
lung.
has acute pancreatitis going to look like?
So,
Well, they're
an
going to have
infectious
this boring
purpose.
upper abdominal pain, which may radiate to the back because of that inflamed pancreas. They'll also have a distended abdomen with absent or decreased bowel sounds. They may have nausea, vomiting, fever, hypotension, tachycardia. So they're kind of looking like a septic
Left lower
patient here,
lobe
but they're technically
atelectasis.
not septic.
Left
They're
pleural effusion
inflamed.
infiltrates and crackles
These
and
patients
ards.
may also have pulmonary problems.
Trousseau's and
why is that?
Chvostek's.
Well, it's because the pancreas lies right underneath
That's
that
a
diaphragm, so it can
hypocalcemia
irritate the
sinus.
diaphragm and
Yeah.
it can cause lung issues, most likely on the left side.
It has
such as
ards
left
and,
lower lobe
in
atelectasis,
bold.
left pleural effusion and infiltrates. These patients
You
can
know,
also
I
have
see a
pulmonary
lot of
edema
cases
and
of
crackles
pancreatitis,
because of this
But
inflammatory
none of them
response.
are ever as
which-
sick as like the ones that you learn about in med school.
Really?
Or
Because
defense school.
the ones that we get with acute pancreatitis are sick.
Well, that's also because you're in the ICU. But I think
That's fair.
over the course of like a couple years, like I've only admitted maybe like 2 or 3 acute pancreatitis, and I've
Gosh.
sent home a lot of acute pancreatitis. Just tell them MPO or just like bowel rest, just clear liquids. Zofran narcotics at home.
I guess it depends on the reason they're having pancreatitis, whether or not they're going to be compliant or not.
makes those capillaries become leaky,
Yeah, that's
and the
true. 'cause if
patient
they're
third
gallstones, then
spacing
that does
fluid.
probably need
So they
to
can
come
certainly
out.
develop ARDS. So make sure that these patients have a close lung assessment
But
and to
like
monitor for
idiopathic
signs of
pancreatitis
respiratory
means-
distress. There are a few signs associated with acute pancreatitis due to low levels of calcium, and these are Trousseau's and Chvostek's sign. Trousseau's sign is when there is a muscular hand or forearm spasm during inflation of the blood pressure cuff, and Chvostek's sign is a twitching of the facial muscles when tapping on the facial nerve. Again, both are signs of hypocalcemia. What are some of our other labs going to look like in acute pancreatitis? Well, our lipase and our amylase are two digestive enzymes found in the pancreas. Those will absolutely be elevated in the setting of acute pancreatitis. And something to know is that lipase stays elevated for longer, so it is a more trustworthy measure between the two. Additionally, we'll have a high white blood cell count because of that SIRS response. We'll have a high blood glucose due to injury of the pancreatic beta cells. We will have hypocalcemia, and that's because calcium is used up for autodigestion, and it also binds with fatty acids from necrotic fat. We'll have a low albumin due to leaky capillaries, and potassium and magnesium will also be low due to malabsorption. Treatment for acute pancreatitis includes fluid replacement. However, you must be careful with fluids as to not worsen their respiratory status, especially if they already have crackles or ARDS. You want to replete their electrolytes, specifically keeping calcium, potassium, and magnesium levels normal. Pain management is going to be important for these patients due to the severity of their pain. They may need an NG tube dissection to decrease gastric secretions and to help rest that pancreas. And we can even start enteral feeding below the level of that duodenum. These patients will need glucose control, so remember they'll be hyperglycemic and will need some extra insulin. And of course, if I may have forgotten to mention how important respiratory status is in these patients, monitor their respiratory status for any acute changes.
Okay.
Question number 6.
Pause. B.
I thought you just said that pancreatitis patients get hypoglycemia.
Yeah, but they've also had other complications at the same time with adrenal and everything else, so I don't know if that was due to that or due to the actual pancreatitis, the more I thought about it.
I see. I know you get
So I'm thinking
hypocalcemia,
B.
but I don't know about the glucose.
I think it's B. Because technically what she
follow
just said, she said that glucose control was one of the things she had said, you know?
6. Which of the following laboratory findings would be expected in a
I'll
patient
follow
with
your
acute pancreatitis? A. Hypercalcemia and hypoglycemia. B. Hypocalcemia and hyperglycemia.
JC said B too.
C.
JC said B as
hypoglycemia
well.
and hypocalcemia. D. Hyperglycemia
That
and
sounds good.
hypercalcemia.
Can we just make the CCRN a group test?
We'll definitely get it done. B.
I hope everyone got this one correct. The answer here is B. Hypocalcemia and hyperglycemia. Question number 7. You notice a left hand spasm when inflating a blood pressure cuff on the patient's left arm. The patient was admitted for acute pancreatitis. Which of the following is the most likely cause? A. Positive Schwastik sign, hypercalcemia. B. Positive
Trousseau's.
sign, hypocalcemia.
Schwastick's is the facial nerve,
C.
right?
Positive Kernig sign,
Correct.
hypocalcemia.
And Koenig's is
or
the
D,
left
positive
shoulder
colon
for
sign,
the,
hypercalcemia.
what you call it, the colon sign is around the belly button, so it's B.
I think Koenig's is meningitis.
And the
Sorry.
answer here is
I think it's
B.
like the electric
Positive
shocks.
Trousseau sign associated
What the
with
fuck's in there?
hypocalcemia.
It's like Koenig's
I know
and
we've talked about the
Brzezinski's
presence of
are
hypocalcemia in acute.
the meningitis
What?
signs.
What now?
Koenig and Brzezinski's are for meningitis, unless there's two different Koenigs.
No, you're right. You're right.
Pancreatitis patients, And we know that they're hypocalcemic because calcium is used up for autodigestion. But there are two signs that I wanted to cover that are associated with hypocalcemia that you need
You
to
already
know.
went over
And
Shvastix.
these low calcium levels end up resulting in neuromuscular irritability, which you'll see in both Shvastix and Trousseau's signs. So on the left here, Shvastix sign is going to be seen when gently
Seeing if I have
tapping on the outer
hypocalcemia.
cheek. And you'll see a twitching or a spasm of the facial muscles, which can be seen in the twitching of the lip and cheek here. On the right side here, you have Trousseau's sign, which is a twitching and flexion of the hand and the thumb when the blood pressure cuff is inflated. Again, these are both due to neuromuscular irritability caused by low calcium levels in acute pancreatitis. Question number 8.
A patient is admitted with hepatic failure, ascites, hepatic encephalopathy. Which of the following treatments should the nurse anticipate? No to B. No. Treat dehydration. C. And ascites, I've never seen us treat it with spirulactone. If anything, we do a tap. We would do a tap and just drain it, depending on how bad.
Because usually that's going to be the outpatient management is spironolactone and Lasix.
Yeah, but would you... I don't know. What would you do between C and D?
I would go with D because I think with the dehydration they want albumin.
Okay.
A patient is admitted with hepatic failure. Should the nurse and Mia B provide stone? The answer here is
What's up,
D.
Sentinel?
Treat ascites with spironolactone. So for patients with hepatic failure, you want to do everything in your power to not increase the amount of
Let's see.
ammonia in their blood, as this is going to worsen hepatic encephalopathy.
JC
And for
doing
this
well on
specific
these
question, the
questions.
answer here is D.
Yeah.
Because this patient in hepatic failure with ascites and encephalopathy is going to need a diuretic. But not just any diuretic.
welcome back,
It needs
Sentinel.
to be
You're
a
just in time for the GI
potassium-sparing
section
diuretic,
for
such as
LG University.
spironolactone. You do not want your
Yeah.
hepatic failure patients to be
With Professor
hypokalemic
Skitch.
because it can trigger ammonia production in the kidneys and could potentially cause a secondary acidosis. The answer isn't A, because patients with liver failure tend to develop hypoglycemia, not hyperglycemia like in pancreatitis. B is not correct because sedation should be avoided since it could 1. Mask encephalopathy, but also 2. With liver failure patients,
Takes forever to process
benzodiazepines,
out.
which are metabolized by the liver,
Aw.
will stay in the system for longer, so you don't want to
You
give those
got
and
it,
keep them sedated for long
Sentinel.
periods of time. Lastly, C is
Wait,
not
Sentinel,
correct
are you
because
buying a
lactated
house?
ringers may result in acidosis if the patient can't metabolize that lactate, and it can also lead to an increased ammonia as well. So 0.9 normal saline is the preferred isotonic solution for these patients. Question number 9. You are taking care of a patient admitted for acute pancreatitis. He has developed Cullen's sign. Which of the following has the patient most likely developed? A. Acute hepatic failure. B. Esophageal varices. C. Small bowel obstruction. Or D. Hemorrhagic pancreatitis.
All right. Sketch. I need you to focus up here.
The answer
Hold. Oh my God! They about told the
Esophageal-
answer. I think it's. Sorry. Go ahead.
Esophageal varices doesn't make sense because
Nope.
you wouldn't see that with Cullen's.
Nope. pancreatitis,
then-
right? Hemorrhagic. Small bowel obstruction would not give you that.
Correct. And then I don't think pancreatitis causes hepatic failure, because the only other thing I can think of is like acute hepatic failure and then DIC. But hemorrhagic pancreatitis sounds like,
Sounds correct.
yeah. Like I don't
It's-
remember hemorrhagic pancreatitis being a thing, but it sounds like it's the right answer.
I had someone with colon sign
Here
from what we
is
think was that.
D.
What is colon
Hemorrhagic
sign?
pancreatitis.
It is a petechiae like around the belly button. And then
Ah.
Gray Turner's is usually on the flanks.
Now, necrotizing pancreatitis is the most severe form of pancreatitis, and it results in
Oh, dude,
necrosis of the
we've had someone with necrotizing pancreatitis. Also, that person didn't make it. We found out that they did better for a little bit. They went up to the floor. They came back down in ICU, and then they died and got made comfort care 3 days later.
Mm,
So yeah, that was really sad. But their whole abdomen, just to give you an example of what it looked like, their abdomen was essentially cut out from their belly button, going all the way, wrapping around partially up their backside right here. So from here to here was just an open, gaping wound that kept having to be debrided, and that kept bleeding and hemorrhaging over and over. It was a mess.
yikes.
Are there signs that this is happening to you, like before this happens?
What, necrotizing pancreatitis?
Yeah. Like, is
I
that
mean-
a result of you, like, just your pancreas was having issues for a long time, you just didn't do anything, and then it died and started rotting?
I mean, it's more so, I mean, I guess it depends on how long it's been going on. And then, I mean, you'd get systemic response. You'd have like a fever. You'd have a lot of pain. Pancreatitis is usually pretty painful. So you'd have signs of it. I don't know how early you would see those signs before they would turn like, before you'd have late signs or late stage signs. I mean, usually like if you're seeing petechiae and stuff, it's later. You're having later stages. Like it's been going on for a minute.
I mean, pancreatitis is over the course of days.
Yeah.
Because, I mean, you can get chronic pancreatitis, but that's not going to have like this kind of dramatic presentation. Chronic pancreatitis is just really painful, and you really can't do anything about it, and it sucks. But it's not as dramatic as acute pancreatitis is. So I'd say generally not, because pancreatitis is usually a fairly acute process. So over the course of days, not something where you're like developing it for years and then it flares up one day.
Yeah.
And can you live without a pancreas?
Yeah, Ken. Yeah, you can. You just immediately are type 1.
Oh, because you can't do the sugar and all that.
You also lose a lot of
Enzymes, digestive enzymes.
endocrine capabilities.
Yeah. You can live without it, it's just rough. You're gonna have to take digestive enzymes. You're gonna have to monitor your sugar with insulin. I suggest getting a pump at that point. What's up, Darius? But yeah, they do that. We've had people that they had to do that on because they found cancer on their pancreas and they got scared and they were like, fuck it, take the fucking pancreas. I don't even want to try to go through the everything. They said, has it metsed? And based on the PET scan and everything, they said they didn't see anything that looked metastatic. So they said, all right. He's like, take it out. Take the whole thing.
Which does make sense. You don't really want to play with pancreas cancer.
No, pancreatic, usually if you catch it too late. It's usually stage 4 and you're done. But I mean, if you have the ability to catch it, fucking, yeah, yeah, dude. Ovarian, pancreatic, And there's one other one that I'm blanking on. Those are silent. By the time you get symptomatic, it's usually late stage. I don't think lung is
lung
one of
the
those
other
ones.
one?
No.
I
I think
think
it deals
so.
with a genital, like I think for males. Ovarian.
Prostate.
I'm thinking
Prostate.
ovarian.
Prostate you usually notice because you
Yeah.
can't pee normally.
Yeah, that's
And
not it.
there you usually get a bump or a lump.
Yeah.
It's a lumpy, bumpy, lumpy, bumpy, mumpy.
I'm trying to think of what the. I just know pancreatitis and ovarian are for sure some of the harder ones to diagnose and usually get found really late stage. Because by the time you're getting nausea and you're dropping weight and everything, you're way too far. So I mean, if a lot of people that get caught early in their diagnoses are people who came in for something else entirely and they caught it by accident and are just lucky. Steve Jobs
So
had
can you
pancreatic
catch
cancer.
lung
Yeah,
cancer
Steve Jobs
early?
died of that. Just like eviscerating.
Oh,
as hemorrhagic pancreatitis.
sounds horrifying.
And if they bleed, you may see Cullen sign, which is that blue discoloration and ecchymosis of the periumbilical area. I like to remember Cullen's sign because they both have a C and a U in them, Cullen's umbilicus, or some people like to remember it if you form a C around your belly button, that's where you'll see Cullen's sign. You may also see Gray-Turner sign. If you guys remember, this is a sign of retroperitoneal bleeding, And remember, you have to turn your patient to see their flank bleeding. So gray Turner's side. Another complication of necrotizing pancreatitis is hypovolemic shock. So watch out for these signs and symptoms, as well as the sequestration of fluids in the peritoneum, which may require a peritoneal drain. Question.
All right. You're caring for a patient with end-stage liver disease, admitted with confusion, elevated ammonia, and ascites. The patient's blood pressure is 80/46. What is the best immediate intervention to improve blood pressure? I mean, to be honest, the first thing they're going to do is give a liter. I know liver, you have to watch for, like, respiratory failure, like ARDS and stuff, but I've also was told about laying a patient on their side too. I don't use dopamine too often, so I'm not 100% on that. The silent cancers include lung cancer, pancreatic, ovarian, and colorectal. Colorectal, that's right. Lung cancer kind of depends, though. Lung cancer is usually caught. They can call it silent all they want, but that's usually caught. It just kind of depends on if you have small cell or, like, non-small cell. You know? Like Prager's woman's reposition for low BP. Yeah, that's what I was saying. I remembered something about them saying putting them on their side. But I've got to be honest. I mean, maybe in the book, by the book, they would say put them in that position. But if someone sees a pressure like that, I can guarantee you they're gonna they're gonna quickly give a bolus and slam them first, and then get them on a pressor, most likely. Just saying. But I do remember something about positioning. 3 tablespoons of salt. What's up? Finish shotting. Me and Silly Sam. Shout out to Silly Sam. Are looking for a third. Wait. What are you talking about? Okay, let's see what it is.
Question number 10. You are carrying diabetes. The picture. Is
I
it
think
A,
this is going to be one of
give
those
a
where
1 liter
there's
fluid bolus over
the book answer and then there's the real answer.
Yeah, that's what I'm saying. Like, you can't go by that's where real life, like, experience kind of shoots you in the ass. Because in real life, I think they would do A, but for some reason, I'm thinking B is probably a by the book
20
thing.
minutes? B, position the patient on his side. C, start a dopamine infusion at 5 mics per kg per min. Or D, administer lactulose. The answer here is B, position the patient on his side. So you don't want to give fluid because they're going to third space that fluid since they have low levels of albumin.
See, I figured that, like, that's fine, but I'm telling you, they would bolus it. If they're in an emergent situation, they're not going to dig through all this shit. If they see a blood pressure like that, they're going to bolus them. Because any repercussions they'll deal with later. That has always been the argument that they give me. Like, they'll just say, yeah, cool, we're going to bolus. And I'll be like, yeah, but they're fluid overloaded. They're like, okay, cool, we'll diurese them. If they have respiratory problems, we'll throw them on a BiPAP. Like, that's their response. It is literally what they usually will do. They'll put a bolus, they'll add some albumin on, and that's it. So they're gonna say, you don't give a liter, dude. The amount of people who've been given liter boluses who are already in CHF exacerbation, I'm just saying.
And all of that ascites is going to push up on their IVC. So what you want to do immediately is position the patient on their side because that's going to relieve that pressure on the IVC. It probably would be a good idea to administer lactulose. However, that is not the immediate intervention.
They're talking
for
about the
this
inferior
patient
vena cava
since
when
he
they
is
say IVC, guys.
hypotensive.
Just
End-stage liver disease is characterized by
what is that?
scarring and fibrosis, wherein healthy hepatic
inferior vena cava.
Yeah, what is that?
It's like your main vein. Like right
So,
here
like,
that
for your
comes into
liver?
the, like towards the lungs.
Heart. It's draining all the blood from your lower extremities that's going back
Yeah.
towards the heart. Eventually goes into bigger and bigger veins until they form to join the inferior vena
IVC.
cava, and that leads to your heart. And on the top,
And then
you have the superior vena cava, and that drains from the top portion of your body.
yeah, so it goes into your heart and then goes to the from the right side into the lung to the left side and then to your body.
Take it back now, y'all.
Take it back now, y'all. One hop this time. If you get right-sided heart failure, you'll see like JVD, jugular venous distension in your neck. You'll see like oftentimes it backs up into the body essentially. Just remember right-sided heart failure backs to the body, and then left-sided backs to the lungs. So your lungs will be wet up with left-sided. You can have a
then
primary
the body.
left-sided heart failure, which leads to like secondary right-sided heart failure. Yeah. Brings it back. All your deoxygenated blood. It's back to be oxygenated. You said IVP, IVC. We know what you meant. Excuse me.
cells are destroyed and they're replaced by fibrotic tissue, which does not do what a healthy liver does. So it doesn't filter those toxins, filter medications, and create these plasma proteins such as albumin and clotting factors as well as a healthy liver does. And in end-stage liver disease and chronic liver disease, portal hypertension will be present, since that fibrosis and cirrhosis of the liver significantly increases.
Isn't that when
hepatic
usually they
resistance
would do like a TIPS procedure with someone with portal hypertension?
Correct.
And we had a patient with like sometimes the TIPS procedure fixes the problem, and then sometimes like the patient just needs a liver transplant at that point. But I've had some that got a TIPS procedure and they did significantly better and they were fine. They were getting tapped for a paracentesis like what was it, every week, sometimes twice a week. It was that bad. And then they got a TIPS procedure and they were significantly better.
and portal vein flow, it leads to this increased portal vein pressure and over time, portal hypertension. And this increase in portal vein pressure ends up traveling upwards. And it also increases the blood pressure inside the veins in the lower esophagus and the stomach. And since those veins aren't designed for higher pressures,
Dude, esophageal varices are scary if you've seen like a bleeding esophageal varice. It's like traumatic and emergent. Like the person is just essentially pooling blood and aspirating it too.
That was
That's
probably
where
one
they're
of,
breathing it in.
yes.
Yes.
That was probably one of my scariest intubations, was an esophageal variceal bleeder.
Yep. We had one on a 25-year-old and they died. We had pressure on them. Yeah, we had 6 of us taking that patient down to interventional radiology. We were doing everything we could do. We had a balloon that was placed in the esophagus against the pressure of the bleeding varice, and we had it held out with a long ribbon that was then tied to a weight on the other side, and one of us had to hold traction to it, and then it got deflated, and then the IR like physician had to run back in and quickly try to inflate it, reposition it. Like, it was a whole thing. That patient was a 1-to-1 They were so sick. There was 2 nurses in that room almost at all times, just slamming him with blood products. And then finally, after like I think it was like 70 blood products between FFP, packed red blood cells, like platelets and everything, that finally the mom like agreed that this wasn't gonna fix. Like, she didn't realize he had such a bad alcohol problem is the problem. She was unaware. And he got esophageal varices and he bled out, so his siblings had to come say goodbye. Like, it was very tragic. It's a very sad situation. But yeah, it was the scariest thing. There was literally about 7 to 8 of us downstairs off the unit at one time. Like, we all just left. We had other people watch our patients. Primarily, most people in the unit were okay. And we had 2 respiratory therapists with us. Like, it was a whole thing. We had our charge with us, like, while we were just waiting on standby, because the whole time we were watching them dump blood into the tube. Like, we were watching blood just get suctioned out of the mouth. They put a yonker down in there, and we were just watching blood flow out of it into the suction canister. And we're like, well, there went all the blood we just gave.
What do you do when you know? And tell me if it's too much of a question, Ash, but what do you do when you know, like, when you just, like, know they're gonna die, and you're just like...
You just exhaust yourself, because, like, you're gonna do everything, like, because the parents want everything.
Yeah,
I mean, they're young, you know? They're gonna ask for everything,
I know
but...
obviously you're gonna... But, like, how do you, I guess, like, handle that? Like, if like you personally, like, if you're like, this kid's dead, like, we are prolonging his death, basically.
I mean, you just, I don't know. You just do it. You just do whatever you've got to do in the moment, your tasks, like what you got to do to say that you've done everything, essentially. Like, that's all you can do. I mean, you run out of products. Eventually, we have to order out to Red Cross. We've used up all of our supply. Like, we don't keep that much on us at once. So sometimes we were having to just go ahead and ship them out. And then you have to unthaw, like with your FFP, you have to like unthaw those. Those take about 30 minutes to 45 minutes. Like, you just have to have things on standby. If you're transfusing, you just got to know you need more, and you got to go ahead and say, I need 10 products. Go ahead and order them, send them out, like, so that they're going to be ready in time. And you keep slamming them with products until like enough physicians have talked to the family to say, hey, right now we're dumping blood, and you see those canisters, we're filling them back up. We cannot stop the bleed. They're hemorrhaging out. Like, we are wasting blood products. As bad as that sounds, no one wants to hear that, hey, I'm wasting products on your child. But at the end of the day, there are people that can survive and that aren't going to get those products, because you're putting them in somebody who's not going to get better. They did this dance for 2.5 days where they just slammed products. That's why there were 70 products given. That's a lot, just so you guys know. 70 blood products is a lot of blood products to give a patient in a 2.5 day period. It's not a normal amount. You're running multiple at once. You're running it as fast as they're draining it. And there's nothing you can do to change that. And because they also have liver failure, they're not clotting, so they're bleeding.
And you're running it faster than normal, because generally you would infuse it in about 2 hours to 4 hours.
Yep. You usually run products slow and one at a time to look for transfusion reactions, but when you've got someone hemorrhaging blood, like, you're doing a mass transfusion protocol at that point. You are slamming bags. You have 2 piggybacked PRBCs with platelets running at the same time. You've got it all going. Like, you don't even care at that point. You're also pumping them with calcium because they're leaching calcium. After so many products, you have to give calcium supplementation. Like, there's so many things that get off balance when you're slamming someone with that much product.
Because then you have to try to do a balanced resuscitation where you're doing a 1-to-1-to-1 of FFP, platelets, and RBCs.
Why am I getting condom ads? I don't know. Sorry. What'd you say, Sketch?
Or in my case, my esophageal bleeder was a Jehovah's Witness. So basically, I was in a boxing match with Mike Tyson with my hands tied around my back and my feet shackled to the floor.
Oh, because they didn't want, like, any of the treatments, or?
Nope. A Jehovah's Witness will not accept blood products.
Yeah.
What? So you're just like, all right, well,
They want you to do
So then,
everything else.
right.
Gil
So
Puitin.
then, kind of like one of the classic ethical dilemmas is like a child whose parents are Jehovah's Witness and they're brought
Mhm.
up as a Jehovah's Witness and they're bleeding out, and you might be able to save them with a blood transfusion, but if you don't, they'll almost certainly die. And then like the question is like, what do you do in that situation?
I mean, I can save the child, but is that the correct answer to that question?
I don't
Like,
know that there is a correct answer, is the issue.
I mean, in my book, it's hands down save the child.
In my book, right?
And
Like,
then the
here's how I
rest
feel like. I
parents.
feel like, right. I feel like in my book, if you have a kid who's under 18 and you deny them life-saving treatment, that's considered a form of abuse, like, or in child endangerment. That's my opinion. But because they will disown their children, I've seen situations where a family, a full family of Jehovah's Witness will absolutely disown, verbally tell them if you accept products, like they'll stay next to their child who's like 18 or 19, and they'll say if you get this product, you're done. If you get this product, like I'm not gonna don't come back with me. Like they'll stay at bedside to
I
make
found that
sure that you don't
attempted
convince
murder.
them.
Fuck that.
Like literally,
Is
and they'll
that
be
similar to
crying.
Fuck
like?
that.
It's similar to
That's
like
second-degree
Amish
murder.
people as well. Because some Amish people don't like that kind of thing as well.
It's crazy. Like I mean,
Yeah, like if
they believe that it's a contaminant to bring someone else's blood into your body.
That's screwed.
So Ash, this hits the line. So you believe whatever you want. I don't care. But once you do something like that and you're harming people, nah, fuck you. Like, believe whatever you want. I don't care. I respect your belief to stuff. But once you start harming people, including your own child, like, no, fuck you. Go to jail. Don't pass go. Like, get the fuck out of here. Go to prison. You don't deserve a child.
I mean, it's crazy. I watched a
Like,
wife die because the husband and her were Jehovah's Witness, and she just believed. She's like if the God's gonna save me, he's gonna save me. I'm telling you, she looked so whitewashed. By the time all of her color drained out, I'm telling you, it was the scariest thing. I've never seen someone's lips that pale and some of that white. She was like cold sweating. She was like, her eyes were rolling back. She was getting very fatigued. Like, no joke, sketch. 1.9 hemoglobin. And then she died
Yeah,
the day later.
my record is a undetectable hemoglobin.
Dude, it's wild. If you don't have hemoglobin, you can't carry oxygen. You can't carry oxygen, your vital organs will shut down. You're gonna get
Yeah,
loopy because you're not
it's
receiving enough oxygen to your brain. Like, that's essentially what's happening. You're slowly starving and depriving everything of oxygen over time. Like, she just would not accept any products. She was easily saved with products. She didn't even have a detrimental diagnosis. She could have easily, like, came out of that. But yeah, no. Albumin, erythropoietin, like, those are the only things, like, all of the, like, other properties that you can give that aren't from another person, they were willing to accept, but nothing that was actually from a person. No actual blood products from another person.
yeah, because they basically
ETOH
believe
alcohol.
that they can't get in, they won't get into heaven if they accept blood products. So their belief is basically, I would rather go to heaven when I die than take blood product.
Do you let them know that if he doesn't receive these products that they're gonna die?
You all do, all
Yeah.
of them, everybody. Every physician has had that talk. Like, we can prevent
And
this.
they're just like, no.
But you're also taught in
Yeah.
medicine that you're not able to discriminate and you can't go against people's religious
Yeah,
beliefs, and
I
you have
mean-
to be honorable to everybody's practices, including their diet preferences and everything. And if they're Jewish and they have a specific time in which they don't eat certain whatever, you have to be mindful of all of it. And you cannot use any words that are considered demeaning or judgmental.
Yeah.
So Ash, I'm just gonna say, when it comes to the parents with the kid, like, fuck them, like into the prison you go. Yeah, no, you want to die, okay, whatever. But if you're killing your kid off, nah, go fuck yourself. Like,
These are the ethical
I know
dilemmas
you
we
can't
have.
say that.
These are the
Yeah,
ethical
like,
dilemmas. And the same
that's-
thing. The same thing when you have like
I
a
get
like a
tired very quickly.
if you have a patient who has a common law, like, spouse, they were never married, they have biological children, they have biological, like, siblings alive, parents alive, everything, that common law person has say over all of them, over all the blood-borne, like, people. Like, that person can make the call. So if that person
Yep.
says DNR, the mother of that person can't say anything, the siblings of that person can't say anything, and the children of that person can't say anything. That is their call legally.
Why is that a thing?
It
So
is.
unless so you can designate
No,
someone
I'm asking like,
Unless you-
your power of attorney, but
Right.
by default it goes spouse, and then I think it goes to
Children.
adult children,
Yes.
and then parents, and then it gets more muddied where I'm like, social work, who the hell is the is the designated decision maker? Once you're getting in like uncles,
You get ethical
cousins, or
on.
things like that,
You get
then it's
ethics
like-
involved too. It's those get muddy. Trust me, we've seen it. We've seen it where common laws will refuse to have patients' family see them while they're in the hospital. They'll say, "I don't want anybody in there," and they can literally say that legally, and you have to honor it, even if you don't agree with it. You can watch their whole family cry on the outside of the room and not be allowed in, and it's the rule. Like, they can sue you. They can sue the
that
hospital.
is,
So because of lawsuits, they're not gonna challenge it.
oh my god, Ash, I would be fired day one.
I'm telling you, it's not for the faint of heart. You run into a lot of ethical things in situations with people who are critically ill, and a lot of elevated emotion.
Yeah,
So
I wouldn't do very good with that. I'd be all like, fuck you, get out. One Jehovah's Witness would be the end of my career, Ash. Sorry,
yeah,
one
it's
Jehovah's
it's their
Witness would be
religion though. We watch people die all the
No,
time
like-
that.
It's fine if you make the decision for yourself. Is my thought. Like,
Yeah.
if it's for yourself, okay. But if you're doing it for someone else, like, and especially a kid, because I feel like a kid doesn't have the capacity.
I
to,
agree.
like, fully understand the ramifications. So it's like, yeah, okay, you want to make that decision yourself. You believe that, okay, whatever. I don't care. But now, if you're affecting a child, it's like, well, the child doesn't fully grasp. They haven't been able to make their own decisions. So like that's the one where I'm just like, or even if you're like, well, yeah, mostly just a child for that, because everyone else could make their own decisions.
Yeah, and there's always like different scenarios too, because it's like teenager is different than like a toddler, right? Or
Right.
like the teenager's on board with it. You're still kind of like, but that feels better
Wrong.
than a toddler
Yeah.
who you're like,
Yeah.
definitely don't understand what's going on. You've never been able to make this decision, and you never will be.
Yeah,
able to.
zero.
Yeah.
Yeah, I mean, I don't know. It's wild. Like, you'd be surprised. Things are crazy. Okay, let's go forward.
They begin to expand, which is how these patients end up developing esophageal varices. Of course, we'll also have encephalopathy from the buildup of ammonia, which the liver can't filter. And lastly, there is hepatorenal syndrome, which is kidney injury due to liver failure, because when the liver fails, it takes the kidneys down with it. And now, what causes this chronic end-stage liver disease? The number one cause of chronic liver disease is chronic alcohol use. Drinking significantly destroys those hepatocytes and scar tissue ends up replacing healthy tissue. Some other causes include fatty liver disease from obesity or diabetes, or chronic hepatitis. And these patients are going to present with altered mental status due to hepatic encephalopathy.
Dude, it's
They can
wild.
present with hypotension, shortness of breath from their
Seeing someone that
ascites.
altered.
They could be jaundiced, and again, that will appear in the sclera first. They can have something called asterixis due to high ammonia levels, and this is when you ask a patient to hold out their hands, and their hands kind of do this like flapping, tremoring motion. Now, how are we going to treat end-stage liver disease? Well, if your liver is completely cirrhotic, there really isn't that much that we can do short of a liver transplant, but we certainly want to treat the cause if we can. So we want them to eliminate
JC.
ETOH from their diet. We want to treat their symptoms as best as we can and give that supportive care. We
Cathode.
can also do what's called a TIPS procedure, and this stands for transjugular intrahepatic portosystemic shunt. You don't need to memorize that, but you do need to know what a TIPS procedure is. This is for patients with end-stage liver disease and cirrhosis, and what the surgeons do is they relieve portal hypertension by inserting a stent, and that stent shunts blood from the hepatic vein into the portal vein, and it bypasses the liver. And this helps decrease portal hypertension, which in turn also helps relieve esophageal varices and ascites. These patients will generally have ascites due to the low albumin levels and their portal hypertension. And when patients have ascites, we do usually put them on a fluid restriction. We give them potassium-sparing diuretics, such as aldosterone antagonists, so your spironolactone or your loop diuretics. We also want to make sure that we're measuring their abdominal girths and daily weights. It's going to be important to position these patients optimally. And what I mean by this is that these patients will have these large, fluid-filled bellies that may be pushing up on their diaphragm and pushing up on their IVC. And this is where we get the symptoms of hypotension and shortness of breath. So you preferably want to position these patients either lying on their side or in reverse Trendelenburg in order to decrease that pressure pushing up on the inferior vena cava. You certainly want to monitor these patients' urine output and look for signs of hepatorenal syndrome.
Darius.
Definitely not a first-line treatment, but if needed, you can do a paracentesis, which is a temporary resolution. Most patients in end-stage liver failure will need weekly or bi-weekly paracenteses in order to keep draining that fluid that accumulates. Question number 11. A patient
Reverse Trendelenburg,
JC.
JC.
Tube or an esophageal balloon tube for the treatment of bleeding esophageal.
Esophageal balloon tube, that's what we were using. Dude, it looked so jank. We no joke took the end of that and tied it to a bag of, a liter bag of saline, and then hooked it over the IV, like, pole.
I mean, that's what you're supposed to do.
I mean, but trying to transport that patient and move them from table while keeping it, like, that taut is very fucking hard when you're managing, like, airway and, like, half a dozen other tubes on the patient and all of their, like, lines from pressors and everything. Like, you're literally, that's why it's a team.
There's another tube like it called a Minnesota tube. And so we had that at our hospital, and when I had my GI bleeder, we thought about putting one down. But guess what? All the ports don't interact with our syringes. So our charge nurse had to, like, rig up some janky thing where she, like, took a bunch of different pieces from different things and, like, put it together to make it fit.
JC said this is a hospital, not your bedroom. Sorry, go ahead.
We had to hold it a very specific way so it wouldn't fall out and it would fit, and then you could inflate the balloon, but otherwise you couldn't. So it was, yeah, that was some real MacGyver stuff.
That's why they pay you the big bucks, Peter.
All right, Sketch, you ready?
I didn't figure it out. Our charge nurse did.
Ah.
See, when I have a problem, I go to our charge nurse and I say, "Please help me."
And this is why I'm glad I don't do charge nursing anymore.
Wait, I thought you were a charge nurse.
I was on my unit on PCU.
Ah.
When I moved to
Are you just,
ICU, no,
like,
I foregone that.
Are you like regular nurse now, or?
Yeah, like I take care of patients. Charge nurses in ICU don't take care of patients. They strictly have no patients. In PCU, we had patients still. We had 2, while the rest had 4. Let's see. Okay, so patient has an esophageal balloon tube for the treatment of bleeding esophageal varices. What is the following is specific to the care of a patient with esophageal balloon tube? This is A, initiate fluid resuscitation, B, which is not it, B, monitor for overt bleeding. I mean, I guess you would hope that there wouldn't be any bleeding if you had the tube in place, or the balloon. Administer an H2 agonist, or D, keep scissors at the bedside.
I feel like it has to be the scissors. Like, it's such a dumb thing, but I'm like, everything else you would do in other situations too, and this is asking specifically just in this situation.
Yeah. So D. Ready?
Ready, Freddy.
Varices. Which of the following is B, more in H2?
He said cut that tube.
And the correct answer here is D, keep scissors at the
I
bedside.
just thought of something slightly
So in
worse.
the event that the tube becomes displaced and it moves up, the esophageal balloon may obstruct the airway and result in an acute airway emergency. I know we briefly touched on esophageal varices, but we'll talk about them a little bit more here. So esophageal varices are dilated, engorged veins in the esophagus. And how do they get to be dilated and engorged? Well, cirrhosis prevents normal drainage through the liver, which results in portal hypertension. And with portal hypertension, those high pressures also back up into the esophageal veins, which is what causes these varices. And if these varices burst, which they have a high likelihood of doing since there's high pressure from that portal hypertension, then you're kind of in trouble. Bleeding esophageal varices can lead to hypovolemic and hemorrhagic shock, so we certainly want to prevent that from happening if we can. Endoscopically, patients can undergo banding or sclerotherapy of varices, and if varices do bleed uncontrollably, we can insert an esophageal balloon, which is pictured on the upper right-hand side here. We absolutely want to make sure that we don't forget our ABCs in this patient, and we can begin octreotide or vasopressin, which both are medications that decrease portal venous pressures. However, we do need to use vasopressin with caution for patients with cardiac diseases, specifically coronary artery disease, as it can decrease myocardial blood flow and cause ischemia, so watch out for ST changes or chest pain. So an esophageal balloon, also known as a Singsteken
Watch for
Blakemore
chest pain,
tube,
as if a person with esophageal varices is gonna know if they have chest pain. Those fuckers are out. If you have esophageal varices, you got a balloon, you're tubed.
basically tamponades, or it pushes on and occludes those varices to stop them from bleeding. And for esophageal balloon insertion, the patient will need to be intubated since there's a chance that the esophageal balloon could migrate up and it could occlude that airway. So always keep scissors at the bedside so that you can cut that tube, which would then deflate the balloon and resolve your respiratory distress. Question number 12. Your patient is 2 hours post gastric bypass surgery. Aru and why? Which of the following parameters should be monitored closely following surgery? A. Lactose intolerance. B. Protein levels and vitamin deficiencies. C. Heart rate, respiration rate, temperature, white blood cell count, and
All right.
MAP.
So
D. Rapid.
you keep the call light within reach. Within reach, so they can press the button when they passed out. Oh my god. Alright, Sketch.
I was
No
gonna
one-
say vitals.
Yeah.
T.
Like fever, post gastric bypass. Make sure you didn't perf anything. Make sure. Trust me, the amount of perfs I've seen, I don't know, man. I feel like complications post
Weight loss.
yo vitals.
And the answer here is C. Heart rate, respiration rate, temperature, white blood cell count, and MAP. So with any kind of surgical patients, you absolutely want to watch out for infection, but especially for patients who have undergone gastric bypass surgery, where there are usually 2 to 3 anastomoses made in the abdomen, and they are at high risk for leakage of intestinal content into their peritoneal cavity because of these anastomoses. So we must watch out for SIRS and sepsis infection criteria, such as these listed here. The Roux-en-Y procedure, or gastric bypass surgery, is a type of bariatric surgery where the small intestine is anastomosed to the upper portion of the stomach to create a gastric pouch which is small, and it holds up to about 30 cc's. And this surgery is elective for patients who are obese and would like to lose weight with the help of a surgical option. It can either be laparoscopic, where they make small incisions in the abdomen and use a camera to help guide them, which is a lot more common since these patients are at high risk for infection and complications, or it can be open, where they do actually cut open the abdomen and have a larger surgical incision. Obese individuals eat large amounts of calories and have small stomachs, so the purpose of this surgery is to bypass the stomach so that it can only hold a certain amount of food. And this prevents patients from eating large amounts of food, thus eating less calories and then losing weight. And these patients must eat small, frequent, soft protein-based foods following surgery, or else they run the risk of stretching that gastric pouch and potentially splitting the stitches of the anastomoses. Even if patients eat as advised, there still is a risk of anastomotic leak, which would include intestinal content leaking into the peritoneal cavity, which is a huge concern. Intestinal content leakage can result in severe infection, so again, you want to watch out for those signs of SIRS immediately following surgery. You also want to keep an eye out on the surgical sites as well, whether it was laparoscopic or open, just make sure that you're monitoring them. For the long term, you want to watch out for signs of dumping syndrome, which is essentially rapid gastric emptying of food from your stomach into your small bowel too quickly after you eat. And this usually results in poor digestion and poor nutritional absorption, so again, having those frequent small protein focused meals are going to be important. Patients who've had bariatric surgeries can also have alteration in absorption, which results in vitamin deficiencies, so it's important to monitor those long term. They can also have hypoglycemia, again, usually due to that dumping syndrome process. And lastly, about half of patients who get bariatric surgeries end up developing gallstones. Question number 13. Which of the following lab values would you expect?
So you would have elevated amylase and lipase. I can't remember if you would with albumin. I think decreased albumin.
I think you're right, because I think it binds to calcium, and that's why you get the hypocalcemia.
So C.
Yes.
Let's do it.
Expect to see in a patient with acute pancreatitis. A. Elevated amylase, lipase, and albumin. B. Elevated albumin, decreased amylase and lipase. C. Decreased albumin, elevated amylase and lipase. Or D.
No,
decreased
not D.
albumin, amylase, and lipase.
Be C.
The answer here is C. Decreased albumin, elevated amylase, and lipase. This slide is just here for reference, as we've talked about all of this previously. Question number 4.
Yeah, she went over that one before, so we'll go ahead and we'll pause this one. Free Radical! I like your name. Thanks for the follow. A patient's abdominal assessment reveals a complaint of dull abdominal pain, abdominal distension, low-pitched bowel sounds, and a report of change of bowel habits. This patient most likely has which of the following? It's not acute pancreatitis because that's sharp, usually not dull. Appendicitis would be sharp and vomiting. I mean, distension. You could have a bowel obstruction. Low pitch. Usually higher pitch, I think, is small bowel. Low pitch is large.
I will say this is not clinically relevant, but I will humor them and say I think it's probably large, because I think you're right. The classical teaching is small bowel has high-pitched bowel sounds. But for the record, no one uses this.
But if you heard
Get
low
us-
pitched, if you heard low pitched bowel sounds, wouldn't that mean your large
Abdominal
bowel
distension,
working, but your small
low-pitched
maybe
bowel
isn't?
sounds, and a report of a change in bowel habits. This
Because if you heard like high pitched, it would be. Maybe I'm overthinking this now. He said use a suppository.
'Cause I was gonna say,
Yeah, you know,
Huh.
when in doubt,
I was gonna
patient
say
when in
most
doubt,
likely has which
suppository.
of the following problems?
Small bowel would be high.
Is it
Large
A,
would be.
a large bowel obstruction, B, acute pancreatitis, C, small bowel obstruction, or D, acute appendicitis?
So Skitch, hear me out.
The answer here is A, a
Large bowel obstruction.
I'm listening.
Hey, we were right before the
Just go
overthinking.
suppository.
Sorry, go. Suppository.
Oh, I'm being stupid.
Couldn't they give us like some Reglan usually helps? It depends on if it's narcotic use though, right? For gastric motility. Skitch.
So that's the difference between ileus and obstruction, because if it's obstructed, it's usually something mechanical. So if it's actually obstructed, you don't want to give anything that promotes gastric motility, because that can worsen it, because then you're trying to push against something.
Right, so wouldn't Reglan like help with that? Obviously not giving narcotics.
Help with what?
With motility.
It does. So you don't want to use it in a bowel obstruction.
Oh, I get what you're saying. Okay.
large bowel
Be more for
obstruction.
ileus.
Correct.
Okay.
Because otherwise, if you're pushing against something that's blocked, then you're just going to cause more distension, and then you'll cause a bowel perf.
Makes sense. Okay. So small bowel obstruction, it says is sharp. Episodic pain, so that one's sharp as well. but bowel sounds hyperactive, high pitched early, decreased late. Vague and dull is large, with hyperactive, low pitched early, decreased in late. Vomiting early for small bowel. It says it can be projectile and or fecal vomit.
All I'm gonna say is,
What
learn
is
this
fecal
for
vomit?
It means stool is coming out of your mouth. You're vomiting it.
What the fuck?
Yeah.
How does that happen?
Because it's obstructed, so it's got to go somewhere. And if you're eating and it's obstructed and you continue to eat, then you have a lot of this buildup and has nowhere else to go. It's going to come out.
So you just shit out your mouth?
Yeah, essentially.
That sounds horrifying.
Yeah.
Oh my god.
Yes, Ken,
You're
you
not
are
the one
correct.
You're not the one that has to taste it.
Gamerland, hey, what's
Oh,
up?
that's so bad.
Hey, Free Radical.
I will
God.
say for this, learn it for the test, but for everyone watching in practice, this is completely irrelevant. Just got a CT. You can't tell based off of exam alone.
Yeah, you really can't. Vomiting is late in a large bowel, obviously, because that's further down. KUB. Yes, 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 yes. Dilated loops, gas-filled bowel. Treatment, your
I learned something
ABCs.
today that I wish I didn't.
You're welcome. NG tube to low intermittent suction, surgery. Says adhesions, hernia volvulus. Electrolyte replacement and treat that pain. And give adequate fluids.
You should be able to differentiate between a small bowel and will be high-pitched, even be
Moving
fecal
forward.
matter. They will also have abdominal distension, but it might not be as distended as with a large bowel obstruction because they are vomiting up and getting rid of a lot of their intestinal content. You will see hyperactive bowel sounds, but they will be low-pitched and similar to a small gate. But patients will have a change in bowel habits, so maybe patterns of constipation and diarrhea, and they will also have abdominal distension as well.
Wait,
In
free
both
radicals
small
what?
and large bowel obstructions, if you shoot a KUB, there will be dilated loops of gas-filled bowel on both x-rays. And when it comes to treatment, the treatment is mostly the same for both. Of course, it certainly depends on the etiology of the bowel obstruction, but as
JC?
always, you have airway, breathing, and circulation that will be your priorities. You want to give these patients adequate fluids and electrolyte replacements. You also want to treat their pain. Probably question number 50.
All right. Your trauma patient is complaining of generalized abdominal pain. He has abdominal distension, shortness of breath, decreased urine output. The surgical resident asks you to measure his intra-abdominal pressure, and you do so and report back that it is 25 millimeters of mercury. Why do you expect... Oh my god. The intra-abdominal pressure is 25. All right, hold on. I'm reading it again. I like to reread after I read.
I don't know. That's why I consulted surgery.
Come on now, Sketch. All right, decreased urine output.
I like how
That's literally my job, which is something is wrong. I don't know what it is, but I know who to call.
Ghostbusters.
Ghostbusters.
I love that your mind went there. Well, I'm like like would it be? I mean, abdominal compartment. If you're compressing, cause like, so if your pressure's 25, that's higher than it should be. You're having
don't know
shortness
what
of breath. It's causing pressure up on your diaphragm. You're causing pressure on your
I don't know
Yeah.
what the pressure should be, but that's the one that makes the most sense to me.
You said you don't know what it should be?
Correct. I don't know what the actual number is, but that's what makes the most sense to me.
Okay. Well, I could have sworn like it was under. He said it's either B or C. I'm going with B. I mean, large bowel was my first one, but then I read it through. But I want to say it has to be under 20. Now I want to Google it. Should I Google it? Hold on.
No, no. I'd
What?
say answer what you think is right first. It tends to help.
Well,
with
that's what I'm
memory
going with.
stuff if
That's.
you.
I mean, that's what I'm going with. Like.
Oh, Oh no, what I mean is like I'd say go with the answer first and see if you're right, then Google it.
Okay.
Wachi is
All right, I'm
not gonna
going
tell
with
you
B.
regardless.
15. Your trauma patient is complaining of generalized abdominal pain. He has abdominal distension, shortness of breath, and decreased urine output. The surgical resident asks you to measure his intra-abdominal pressure. You do so and report back that it is 25 millimeters of mercury. Why do you suspect the intra-abdominal pressure is 25 millimeters of mercury? Is it A, hepatic failure, B, abdominal compartment syndrome, C, a large bowel obstruction, or D, constipation?
Dude, I'm just. It's gotta be. It's gotta
The
be. Please
answer
be right.
is B,
Thank God.
abdominal compartment syndrome.
Hey, nice.
Abdominal hyper.
It usually is. So I believe if it's above 20, like, so 10 is too low. I think 15 to 20 is normal. I can't remember, honest to God. I could be completely fucking wrong here, but I know that anything above 20, and I know that you can test abdominal pressure with a urinary catheter. You actually can if you hook it onto the end. You can. There's a way to check abdominal pressure with a urinary catheter. That's the only other way to do intra-abdominal pressure that I know of, like off the rip.
Hypertension is just a term which means increased intra-abdominal pressure. And what's the big deal with it? Well,
out, you
if
just stick
pressure
a tube
in
up
the
the
abdominal
thing.
cavity becomes greater
They
than
usually
the
already have
pressure
one.
in the vessels that perfuse the abdominal organs, ischemia and infarction may occur, which can lead to serious complications. Some
Oh,
causes
greater
of
than 12,
abdominal
okay.
hypertension include massive fluid resuscitation and over
What is abdominal
resuscitation.
hypertension?
Could be trauma or major
Too much pressure in
abdominal
the
surgeries.
abdomen, like
Signs
elevated
and
pressure in the
symptoms
abdomen.
of abdominal hypertension usually include abdominal distension. If you have a Foley and can measure a bladder pressure, it will be greater than 12 millimeters of mercury. There
Oh,
will
okay,
be
there you go.
decreased urine output as it starts affecting other organs. You can see respiratory compromise or decreased cardiac output. And the most severe form of abdominal hypertension is called abdominal compartment syndrome, which is when intra-abdominal pressures are greater than 20. This is an emergency and decompressive surgery via laparotomy will be indicated. Usually the surgeons will leave the abdomen open as to let it breathe per se or help with all of that extra pressure. And you certainly want to keep an eye on these patients' intra-abdominal pressures as well as optimizing the patient's position by placing them in a reverse Trendelenburg. You certainly don't want to have their head of the bed elevated, which could further compromise the pressure in their abdomen as well as their respiratory and cardiovascular status. And lastly, we have
A patient who is admitted for a bowel obstruction complains of abdominal pain which worsens with movement. Rebound tenderness, absent bowel sounds at KB with free air in the peritoneum. Uh-oh. You would expect the rest of the patient's abdominal assessment to include which of the following? Rigid?
Correct. They would be peritonitic.
Okay.
Feels like
Have
you're
a
touching
bonus
something solid.
question. Your patient who was admitted for a bowel obstruction
Ooh.
complains of abdominal pain which worsens with movement. He has rebound
the
tenderness,
oohs.
absent bowel sounds, and a KUB with free air in the peritoneum. You would expect the rest of the patient's abdominal assessment to include which of the following: a rigid abdomen.
There we go.
The patient being described here has all of the signs and symptoms of a gastric perforation, so they're going to have a rigid abdomen. Otherwise, an intra-abdominal pressure of 5 is normal, since normal IAP pressures are 5 to 10, and abdominal pain with a gastric perf is going to be severe. Now, bowel perforation is a rare but serious and even fatal issue, and this occurs when there is leakage of gastrointestinal content into the peritoneal cavity. And this leakage of GI content and bacteria leads to an infection and an inflammation of the peritoneum known as peritonitis. Some causes of bowel perforation include bowel obstruction, appendicitis, penetrating wounds, ulcerative colitis, or ulcers. And signs and symptoms that you'll see will include a rigid abdomen, severe abdominal pain, rebound tenderness that increases with movement or coughing. You'll have absent bowel sounds, nausea, vomiting, and free air on a KUB. You will certainly see these patients presenting with symptoms of SIRS, such as tachycardia, tachypnea, fever, and an elevated white blood cell count. The treatment here are again, of course, your ABCs, but this will be a surgical emergency where they will have to do an abdominal washout of all of that leaked gastrointestinal content, and they will repair the perforation. Some patients may need a temporary bowel diversion to help them heal, and they usually will have a nasogastric tube to decompression. You'll have fluid, electrolytes, pain control, and antibiotics as part of the treatment plan as well.
There we go. We have finished the gastrointestinal section.
Let's go. What's the hardest section?
Ask Skitch.
You know, I'm offended they didn't include mesenteric ischemia on this.
Hi everyone.
I am so sorry.
Me too.
You want to know something though, Skitch? I got something up my sleeve for you.
Shock and hemodynamics.
Yes. I thought you didn't like hemodynamics, or do you just not like hematology?
Hemodynamics is like what we do all the time. That's
Oh,
like
so you don't mind
pressure.
this.
Yeah, but hematology. Yeah, I'll consult them because, yeah.
He said this can't be from spicy foods, right? Well, I mean, it depends. What's your condition? Bowel condition? You don't want to have your bowel in a state of constant inflammation, especially like, well, if you have ulcerative colitis, you already have an inflammation problem.
Oh, wait, don't kink shame.
Kink shame. Okay. Let's do it, guys. Shock and hemodynamics. So we have neurogenic shock. We have hypovolemic shock. We have septic shock. We have...
So what is shock?
But those are all forms of distributive shock.
Yes.
Wait,
And
what
then
is shock?
There's obstructive shock.
That's fair.
I think
Anaphylactic shock.
is
Mhm.
anaphylactic distributive?
I think it is.
Yeah. Cardiogenic.
Mm-hmm. That gets overlooked a lot. We have to start getting like our echoes on people that meet the certain criteria for cardiogenic shock.
You know, I learned something
AA.
interesting recently.
Talk to me.
The left ventricular outflow tract obstruction can be a cause for
What is
cardiogenic shock that responds
is
poorly
shock?
to stressors.
Oh, he was wanting to know shock. Skitch, answer the question.
I think that sounds like a great question for Ashley to answer.
No, I'm gonna let Skitch answer it. He's better at articulating this kind of shit.
Basically, bottom line is your blood pressure is too low, and you can't get enough blood flow to the organs that need it.
Oh.
Yeah. People in shocker are usually on pressors. And our first line
And
for
if you-
sepsis is
Silence.
levo. And our perfusion is
you-
our vaso.
And if you leave your tampon in too long, you could get toxic shock syndrome.
Yes, you could. Never had that
Okay.
problem.
Was that from the blood? Was
Hey,
that
real
from
Mad
the
Max.
blood, or
Say what?
is that from the blood? Is that from the blood?
From old blood being
you
up
mean
there,
like
it
the blood?
also like festers bacteria,
It-
and then it backs up.
Yeah,
Sorry, go ahead.
basically it's infection that results. Because think of, like, blood is great
Yeah.
for growing bacteria. Like, it's got sugar, it's got electrolytes, it's got
Mhm.
all the things a healthy young bacteria needs to build its home and expand its portfolio and become an entrepreneur and live out the American dream.
JC, you know what that is. Don't play with me.
Oh, I learned a couple of new things. today. Only one of
Vasovagal
which I regret.
syncope. Wait, what? In regards to what? Free radical. Blood is very yummy for bacteria. Yeah, that's the reason why they get pissy. Whenever you have antibiotics hooked up to a central line, and if the antibiotic's done running and you shut it off, but you don't clamp off the line or flush it, they get pissed because blood backs up into the line. Then it's a bacteria like festerer, and then that's how we end up like with a patient who has a secondary infection due to has a primary, resolving the primary, then gets a secondary because of their central line. So then they have to do like a whole sepsis workup on like blood cultures and whatnot, urine cultures, to see what the cause of the problem is for all of a sudden a spike in their white count and having a fever or whatever. Anyway, that's why they get so pissy about central lines being flushed and capped and, clamped. Heir of the Empire. Yes, it is, young Padawan. That's cute. Alright, here we go.
Nurse Jenny here from Nurse Life Academy, and I'll be reviewing questions and concepts related to hemodynamics that you must know for the CCRN exam. I will time mark this video, so feel free to just scroll through at your own pace, but I do give extra information and explanations
Ooh,
after
I need a
every
drink.
question to really
And I have to
reinforce
pee.
the
Hold on.
content. Keep in mind that this is just a review, so if there are things that you
Thanks for
aren't
sharing,
familiar with,
Ash.
go back,
problem.
review the information until you feel comfortable and can answer these questions correctly, because these are questions you want to have mastered
Yeah,
before
Skitch
going
never
into
tells
the
us when
exam.
he has to pee.
I would greatly appreciate
Make
if
sure
you
to
like and
chart your
subscribe
eyes
to my
and
video
nose.
if you found it helpful,
Ashley.
but also so that you can be notified of other videos dropping, which I plan
sure
to
to
do
what?
about every other week or so.
Chart
So
your
without
eyes
further
and
ado,
nose.
let's talk about shock
Your
and
ins and outs.
hemodynamics,
How much
one
you're
of my
urinating,
favorite
So
topics.
how much you're
Well,
losing, and
It
then
is
how
now
much
that I
you're taking
understand
in.
it, but let me tell you,
So then
was
you
I
use that to track
terrified
your
when I was
overall fluid
learning it for the
balance and
first
figure
time
out
and taking
how
care of
much
patients
someone
with
is either up
swans.
or down on the fluid.
But I promise
Usually
you
up over
that
the
what
course
you
of a
need to know for
hospital
the
stay, and then
CCRN
you end
is
up needing
really
to
not as
diuresis
difficult as it
and
seems,
make them
and I'm
urinate out
hoping
that
to show you
fluid,
that throughout this
'cause then
video.
they get
You can absolutely
very
do this,
fluid
so let's get
overloaded.
started. Question number 1. Your patient is admitted for acute on chronic heart failure and a PA
Do you
catheter is
track your
placed.
intake, Skitch?
What changes in hemodynamics would you expect to initially observe after
Nah,
a dose
I
of
work in the
furosemide
ER.
40 milligrams
track
IV
nothing.
push is given? A. Decrease in CI
Do you
or
guys
cardiac
actually not track
index.
stuff?
B. Decrease in preload. C.
Not
Fuck.
Decrease in
those.
afterload.
Wait, I
Or
gotta pause
D.
We
it.
don't,
I
we
don't
don't
wanna
have the
miss
time
in
for it.
SVO2.
It doesn't matter for us.
Missed it. I don't want to miss it.
Ash, are you good?
I was running. I heard the question. I didn't want to get left out. I still have to pee. I went downstairs to take a drink and then realized I had to pee more. Wait, hold on. Let me go pee. I'll be right back.
So, Skitch, how's your day going?
I'm hard stuck in flat.
I mean, yeah. Just kind of how it goes.
Listen, I just want to make it to Grandmaster so I can have a cute little badge on my name.
I like how you just want the icon.
I just want the cosmetic rewards. That's all I want.
No, not that.
Okay. All right. Your patient is admitted with acute on chronic heart failure and a PA catheter, pulmonary artery catheter is placed. What changes in hemodynamics would you expect to initially observe after a dose of Lasix intravenously? Okay. Give me a second, I gotta think through it. This has always been a frustrating one of mine. Doesn't it really? Does it reduce preload?
That's what I'm going with.
Okay, that's what I thought. Isn't also beta blockers reduce preload?
No.
Or is it
doesn't
after?
affect the volume status. It would.
So is it
act
afterload?
on- Yeah.
Okay.
But they might also decrease the cardiac index because it would decrease contractility and heart rate.
I mean, that's fair. Okay, well, I'm going with preload on this one. JC, we're going with B. What do you do
And
that
the
you have no
answer
breath? I ran to the
is-
bathroom and peed really fast.
B. A decrease in preload.
High five,
So,
Sketch.
furosemide is a diuretic, which means that the patient is
Woohoo.
going to diurese, and in doing so, they're going to lose volume, and that will be seen as a decrease in their preload. If you do remember back to the cardiology lecture, can you
No, I
name
don't,
any
'cause I didn't watch
preload
the cardiology
reducers off the top
lecture
of your
yet.
head? So there's diuretics, maybe nitroglycerin or morphine. And what patients do you want to avoid preload reducers for?
People with a heart block, right?
A very specific type of patient. It is patients who have RV
Right.
infarcts, right ventricular
Or ventricular
infarcts.
infarcts. Okay.
I'm just connecting the dots here. If you
Oops.
haven't memorized that chart in my cardiology
Yeah, 'cause they're
lecture, it
preload
might be a
dependent,
good
so if you
idea.
drop them
Wink,
too
wink.
lows, they die. They code.
Okay, so real quick,
Whoop.
let's talk a little bit about the different measurements in hemodynamics that you need to know and what they are. If you feel comfortable with this, feel free to skip forward to the next question. But if not, hang out here with me. So let's start with preload. Preload is a measure of the volume of blood in the ventricle at the end of diastole. It is also known as the stretch of the ventricle at end diastole. It makes sense in my head to think of this as a measure of your volume status. And you do have 2 ventricles, so there are 2 measurements of preload. I did group them together here on the left side. So you have the CVP, or the central venous pressure, which is a measurement of the pressure in your right atrium. Sometimes that's called a right atrial pressure, or RAP. And this is a measurement of the right side of your heart. A normal CVP is about 2 to 6. The second measure of preload is on the left side of your heart, and it's called the PAOP, the pulmonary artery occlusive pressure, or wedge pressure. And a normal PAOP is about 8 to 12 millimeters of mercury. On the other hand, you have afterload, which is a measurement of the resistance that the ventricle needs to pump against in order to pump blood out of that ventricle. Afterload is measured in systemic vascular resistance, or SVR for short. There is also a measurement called the PVR, but that really isn't important for the CCRN, so we'll stick with our SVR. And a normal SVR is 800 to 1200 dynes per second per centimeter to the -5th. Don't worry about the units, just focus on the numbers. To make things easier for us, we can think about afterload, or that resistance, in terms of vasoconstriction or vasodilation. So if your vessels are vasoconstricted, it's going to require more resistance for that blood to flow through, right? So your SVR is going to be high. On the other hand, when you're vasodilated, the SVR is low because those vessels are open, and that blood in the left ventricle won't be meeting much resistance being pumped out. Moving on, we'll look at your PA pressure. Similar to a blood pressure, you have systolic and diastolic, and a normal PA pressure is 1/4 over a dime, or 25 over 10 millimeters of mercury. I did include SVO2 here, and this tells us about oxygenation at the cellular level, and the normal here is 65 to 75%. I also have cardiac output and cardiac index here. So cardiac output is how many liters of blood your heart pumps out per minute. Normally that's 4 to 6 liters a minute. And lastly, the cardiac index, which is your cardiac output, but it is modified to account for your body surface area, so it's a little bit more accurate compared to the cardiac output. And you'll generally see the cardiac index used on the CCRN, but that's not to say you shouldn't know the normal range for cardiac output, because that might be on there as well. Question number 2. Which of the following shock states would most likely result in an SVO2 of 83%? A. Hypovolemic shock. B. Anaphylactic shock. C. Septic shock. Or D. Cardiogenic shock.
Skitch, you still there?
Yes.
This is saying which of the shocks? Sorry?
I decided I don't like hemodynamics. This is all like swans and like all the stuff that I'm like,
I don't deal with
is
this
not
either.
stuff that I-
This
yeah,
is
I
this
don't
is
deal with
great.
it.
This is great shit for like a CVICU.
I was gonna say this is really relevant for like anesthesia though.
Yeah, the SVO like 2 though. This is not the normal range. This is over the normal. So
What is SVO2?
it's what they said at the cellular level, the oxygenation at the cellular level, 65 to 75. So trying to think like this just doesn't. I've never heard of it asked this way, and I never deal with SVO2. I never look at SVO2. I don't know, like cardiogenic. I don't know. Activating lurk mode. Oh, he went into the lurky lurk. Gonna go shovel snow. Okay. We're all wrong. Septic shock. I'm not sure why.
C. Septic shock. So the first question we're going to ask ourselves here is
Let's
an
please ask it.
SVO2 of 83% normal?
No.
And the answer is no. Normal SVO2 is 65 to 75%.
Yep,
And if
that's
it's
what
too
I just
high
said.
or if it's too low, either
Then-
way, it's not good for the body. In septic shock specifically, the increase in SVO2 is related to impaired cellular oxygen saturation. What I mean by this is that oxygen delivery, or DO2, is adequate. However, oxygen utilization, or the extraction of the oxygen from the blood, which is VO2, is what's low. A sign of poor oxygen utilization when oxygen delivery is adequate is an elevated SVO2, because oxygen is not being used
Utilized.
despite its
Okay.
availability.
Okay. I get it. I'm not quite sure why only in septic shock it would be that way, but it's saying it's a utilization problem. Like, so if there's too much that it's picking up and it's higher than what it should be, it means it's not utilizing it properly when it's elevated.
And blood is returning to the pulmonary artery with more oxygen than expected. Let's talk about early or warm septic shock. The hemodynamics of early or warm septic shock include an elevated cardiac output and index, because early on the sympathetic responses kick in. And this massive inflammatory response and endotoxins are going to increase capillary permeability and cause significant capillary leak, which will decrease your preload. Additionally, this inflammatory response is going to cause massive vasodilation, which is going to decrease the resistance of that blood pumping out, so you'll have a decreased SVR. And then to reiterate the SVO2, increase in SVO2 is related to this impaired cellular oxygen saturation, where the oxygen delivery is adequate, but the oxygen extraction from the blood is low. The hemodynamics of early or warm septic shock do differ from the hemodynamics of late septic shock, so just make sure to keep an eye out for that. Most of all, the early or warm septic shock is going to be tested on the CCRN. So for sepsis, we have an evidence-based bundle, which includes labs, fluids, and antibiotics. And you do originally want to draw a lactic acid, which you will treat and trend until it's normalized. You'll want to draw blood
Every
cultures
3
and a
hours,
CBC.
reflex.
For fluids, we're going to be giving 30 milliliters per kilogram crystalloid bolus to start. And after that first 30 ml per kg fluid resuscitation, you want to make sure to assess their fluid volume status. And if they're not overloaded, give more fluid. If your MAP is persisting below 65 despite that aggressive fluid administration, you may want to start pressors. Levofed or norepinephrine is going to be your first line pressor for septic shock. So
Here we
I
go. Here's
with
the
my
chart.
obsession.
Here's the chart sketch. Said I'm not guessing anymore. I'm too out of my league. Aw, come on.
Here's Skitch just saying that.
Sketch. Sketch.
Ashy's trying to rank up in Marble Rivals.
I thought he was still paying attention.
I mean, he's multitasking.
You can't
what
multitask
I'm
this
doing.
kind of shit.
Sure you
God
can.
damn it, Sketch. Skitch, you've disappointed me. Crystal Rose, thanks for the follow. I'd be guessing, but I'm trying to build a website.
Wait, who's building a website?
Hitting Skitch right in them feels. Yeah, he doesn't care. He's too busy.
Honestly, he could be pooping.
Nah. He would still speak to us.
No. No, he does not speak. Okay, he had spoken to me once when he was pooping, but I probably shouldn't be telling people that.
It's okay.
Sort of. Just pretend I didn't say that. Just pretend I didn't say that.
We'll pretend. I felt like my heart was gonna explode one night. Didn't want to look up what I did. Wait, what? Didn't want to look up what I did? Oh, you looked up what? You thought you were having a heart attack? Were you having an anxiety attack? Sorry, I'm looking over this chart. It's a lot, but here, we'll go ahead and...
With charts, and I know it looks scary, but I promise you it's not. This really just helps keep things organized. And I'm not going to go through all these right now, but these are the shock states and the treatments that you need to know. I've included the normal hemodynamic values up top here. And since there is discrepancy based on who you ask or various textbooks or sources, on the CCRN, when they give you hemodynamic values, they are going to be obviously high or obviously low. So if you see here that I have an SVR as 800 to 1200, but you have it memorized as 900 to 1200, do not worry. The questions are not trying to trick you. So just memorize these values or values from a trusted source such as Barron's or past CCRN, and you will be fine. Question number 3. A patient with an acute anterior MI has a PA catheter with the following hemodynamic values: cardiac index of 1.8, PaOP of 18 millimeters of mercury, SVO2 of 48%, and SVR of 1820. Which of the following would be the most appropriate for this patient?
A lot of vascular resistance. So in the afterload, so they're clamped down, they're underutilizing, or they're utilizing too much cellular demand. Cardiac index is under what it should be because they're putting pressure from the systemic vascular resistance, decreasing the cardiac. And hold on, let me think about this. Levofed is just going to clamp it down more. Dobutamine might help with contractility and not act as much as... What's an inotrope though? I wouldn't want to increase the afterload. It's already high enough. Between B and C. Dobutamine is more so for cardiac output. I'm trying to remember the beta receptors. Yeah, I'm between B and C, like honestly. Skitch. Is he still taking a shit?
I don't know what he's doing. He's either taking a shit, he's cooking something, he's eating something. Like, he's doing something.
Is it A?
We're gonna go without
start
him.
a
Say nothing if you're
norepinephrine
pooping.
infusion. B. Start a dobutamine infusion. C.
I guess he's
Start
pooping.
a 1 liter 0.9
Because usually
bolus over
milrinone or
2
dobutamine
hours.
are our
Or
go-to.
D. Increase the afterload.
And that's for contractility. Increasing cardiac output and
And
index.
the answer is B.
Okay.
You are going to be starting a dobutamine infusion for this patient. So here we go. What I'm sure everyone has been waiting for, a question that gives you hemodynamic values. When you see this on the exam, you are not going to hyperventilate because we are going to break it down. So it looks like all of the values here are out of range. So we
Mhm.
certainly need to do something. And looking at their preload, the PaOP is already 18, which means that they're fluid overloaded since blood is backing up into the pulmonary system. Do not give them fluid because if you do, you're going to drown them. And what you need is more squeeze and a diuretic. We'll go back to the previous question in just a minute here. But first, let me give you a foolproof method to master these hemodynamic questions. If you're cool with this, no worries, just skip ahead. If
No,
not,
free radical and SVO2. So there's a difference between the PO2 and SVO2. SVO2 is what your cells is utilizing in the body. If it's too low, it's not your cells not consuming enough. If it's too high, or if it's too low, your cells are consuming way more than what you're giving it. And if it's too high, your cells aren't consuming enough. And normally it's between 65 and 75% on a cellular level. Like if you're talking about like your PO2, that's different too, like based off of like ABG lab values. But if you're talking about your just your O2, like from like an O2 sensor, like for a monitor or whatever, then technically for a normal healthy person be 95 to 100%. Although like we're okay, honestly, if you drop down to 92, that's fine. Might put a couple liters on you, but if you're a COPD patient, down to 88 is okay. Yeah, Mad Max. Yeah, no problem. It depends on what we're talking about. Like O2 comes in different stages depending on where you're measuring, if that makes sense.
stay here with me and we're going to go through it. So let's start with the cardiac index. Is it normal and do we need to intervene?
No,
This
it's
is
under.
a CCRN, so your patient is probably going to have an abnormal cardiac index, if I were to guess, and we probably will need to intervene. So, if our answer is yes, we need to intervene, let's move on to the preload. If the preload is low, like it is here on the left side example, we have a CVP of 2 and a PaOP of 4. They are hypovolemic. They need volume. And if their preload is high, on the right-sided example, you will see a CVP of 14 and a PaOP of 19. They are going to need some squeeze. So let's go back to the previous question and let's break it down. Okay, so first things first. This patient is having an acute anterior MI. So right away, my brain goes to that chart in the cardiology lecture, and I associate it with leads V1 through V4 and
Hola.
potential complications of heart failure or cardiogenic
Who is
shock.
talking?
It is I.
What is up, Mav? Skitch has abandoned us and taken a shit or started playing his game. We're not quite sure. And we are going
Cranking his
through.
hog.
He's what?
Cranking his hog.
What the fuck does that mean?
Hey Darius, you wanna explain this one?
For a second there, I
Darius.
thought
Okay, moving on.
Darius is checked out.
Ash, just go on Urban Dictionary.
No, now I don't like it. Now I don't even want to know.
Leave it to
Oh, it's
Zach.
not.
Now,
Listen,
yeah,
it's
leave
not
it.
that bad.
Zach, if you said it, it's probably bad.
What? No, it's not.
It's probably bad.
Ash,
Okay.
I'll give you a hint. It's something everyone does.
Zach, I talk. I know what you're.
What?
No, I know what you're saying. He would not pick in the
Zach.
middle of a study session to wank.
He could. Well, I'm saying he could have gone to it. You know, he could. He's not on stream. That's why he's not on stream. Maybe we don't know. He's not answering. I'm just gonna keep throwing stuff out there till he comes back on.
Yeah, and by the time he comes back, he's gonna be like, "So wait, what now?"
Listen here. I have a. Give me a sec.
It says he's playing Marvel Rivals,
One sec.
like actively, or at least he's in it.
In it to win it. How's your study stream going?
It's going. I needed Skitch to explain a question, but he's been AFK now for like 10 minutes. So I have no idea. He said I didn't want to say anything. I appreciate you. What were you gonna say?
Ash, check
Yes?
The group chat. Check the group chat.
That's not my idea. You jerk. Anyways, okay, so this is actually starting to make my head hurt a little bit. Dude, hemodynamics is in shock as a bitch. There's a lot to memorize, and I think that's what bothers me.
Just all the different
Which
types of
values-
shock, or
It's just the
different
different
ways you can
types
go
of
into
shock,
it.
but you have to know all the measurements within the shock to know how to treat it. But then, like, it's not only that, but you have to understand, like, how it works with preload and afterload, and like when the heart is in like rest and diastole in its
Wait,
filling
what's-
stage, and like
What-
you have to.
what's
Huh?
preload and afterload? What's preload and afterload? Is that like medications or?
No, it's like preload of the heart. Like, essentially, you're talking about where the heart is at rest and when it goes to pump, like when it's squeezing and when it's relaxing. So it depends on, like, you have medications that affect like your preload and your afterload, like, which is what they were just talking about earlier. Like, medications affecting preload include like diuretics, morphine, things like that, and that you don't want to give like preload medications when you have like right-sided heart failure, because like Sketch was saying, you'll kill the patient. Because they need that preload. Those are medications that decrease the preload on the heart. And then you have your afterload, which, and you're talking about like vascular resistance. Like when they're looking at these numbers, they're looking to decide, okay, does this patient have enough fluid volume? Does this patient have too much? Do they have too much clamp? Do they have not enough cardiac output? Like you're asking like what questions, which type of drugs are going to act upon, like which of your inotropic drugs would you use for that situation? Which ones would cause more resistance, which would drop your heart rate more and decrease cardiac output? And you're asking yourself, like, at baseline, what does each shock do? Like, each shock, like, being that, like, each shock stage has its own criteria that it meets for, like, what it decreases. Like, does it decrease or increase your cardiac output? You know, does it increase or decrease your vascular resistance? Like, what would you see with SpO2? Like, what on a cellular level would your like cells be utilizing or underutilizing or overutilizing depending on what shock stage? So you would need to know, you need to be able to look at that, say how you would treat a patient with this set of numbers, and then also say, what would you see? Like what stage of, what type of shock would this be given these numbers? And how would you treat that shock as a primary, like for primary medication or whatever? Surely this was a hard thing. No, we're not even in cardiovascular, motherfucker. We are just in hemodynamics and shock. That's what I'm saying.
Yeah,
Like
we haven't
it's
got to
just
the fun part.
it's just a lot. Yeah, no, then you get into like the reciprocal leads of like a heart attack and like an MI, where they might have like an occlusion, like where you would see ST elevation, like in what leads, what would their reciprocal leads be, like then you would determine, like you would go through and say what each, is it a septal infarct, anterior or lateral, like then you like just every section has its own thing. Hemodynamics just likes to focus on like what the heart and systemically is going on with you with different stages of shock and how you treat it. That's just like hemodynamics as a whole, which is why when you talk about hemodynamic instability, people will say like surgeons will often not want to take a patient down who's on multiple pressors or whatever because they deem those patients hemodynamically unstable to go down to the OR because they're higher risk of like decompensation like while they're under anesthesia. So I guess any dynamics is hard as fuck. Yeah, it's just a lot. Like I said, this is, there's a reason why people don't like certain, like, Skitch hates renal and endocrine. I actually like renal and endocrine. Like, I understand that pretty well. Hemodynamics is a little complicated for me. Certain areas of hemodynamics I understand better than others. And there are others that I'm still kind of meh on. And it all depends on what you utilize more, right? Like, so a CV ICU is going to use more of these wedge pressures, like your PAOP, like your pulmonary artery occlusive pressure. Like, you're going to see a lot of those in Swan-Ganz catheters and things like that they place. But they place those and they recover hearts. They do, like, cabbages and stent placements and, like, I mean, they do balloon catheter. They do all of that, like in cath labs and in a CCU or a CVICU. Like, I don't deal with this often, so therefore these numbers I don't look at. Like, these are not numbers that I look at. Like, these are things that they measure. Like, the only reason I know that we do intra-abdominal like pressure is because we've had that missed several times in patients who were post-op. Just because it wasn't something that people normally looked at, and they said there's a way to check it without having to do anything surgically or add anything like an extra line or whatever, that you can check someone's intra-abdominal pressure by hooking it up to like a central venous pressure like line to a Foley catheter and clamp it. And then same with that, you can check a CV pressure with, if you put it to the distal port, the brown port of a central venous catheter, like a subclavian or like an IJ triple, and you hook it to the brown catheter point, you can get like someone's volume status based off of like that CVP. We'll do that oftentimes when we're checking volume status, but we just don't use it often. It's not something we constantly like check. It's just not a normal thing. It's out of the norm. So things that we don't do on a normal day-to-day basis are going to be more difficult and harder for me to like retain because I don't do it all the time. Like some of these things I do early, I do often, so that's why I'm able to respond so quickly to them because I'm used to doing those things. Like, and I understand fully because I deal with that more frequently. So these things are a little bit more challenging just because I don't. So it's not like a muscle memory thing.
We're looking at what value first? Our cardiac index, right? So it's 1.8.
Am I in residency? Oh no, free radical. I'm a nurse.
To help you retain the info.
Thanks, Mad Max, for the 200 biddies. No, I'm a ICU nurse. What'd you say, Zach? Sorry.
Oh, I was saying you're just doing this for fun, right? No, I'm kidding. I know you're doing it to study for the
CCRN.
This
is studying for my so I have to take my my CCRN. So that's just my certification for critical care for ICU. So that's what this is. This is what I am studying for, just to make sure I know all the things by the book. Because we have the things like free radical, we have the things by the book that we do, and then we have the things that are like not by the book. That's why whenever people talk shit like about like nursing being like easy, I'm like, dude, there is more to this than you guys know, like that we have to know. Like we have to know so many levels of these and how to manage every single bit of it. Like our physicians don't manage any of this stuff. There's a reason why they don't know really about it, because we manage all of these things. Like day-to-day basis. Like so like there's an expectation that you know what you're doing and that you're going to know what your first lines are in emergency situations. Like that's why I can't stand when people talk shit. Like y'all better leave me alone. Leave me alone.
And because our normal is 2.5 to 3.5, that is abnormal. Next, we're looking at our preload. So our PAOP
I don't understand
is
any of these numbers.
18.
Yeah, you do. Come on.
I actually really don't.
He said Grey's Anatomy. What about Grey's Anatomy? I mean, Skitch is a doctor, but this isn't his favorite thing. Skitch, where the fuck have you been?
In California.
No, where were you?
I got Micho too.
Okay, well, he wasn't cracking his hog.
Well, there's that. This was
Ash was telling everyone that you were doing that, by the way.
No, I was not. That was Zach's idea. Also, you know what these numbers are, Skitch? Or do you not deal with this at all either?
No, I don't deal with this at all. The last time I dealt with this would have been residency.
You know what SVO2 is, right?
No, I don't know.
Okay, well, I'm going to catch you up then. Now I get to educate. All right. You know what SVR is? 800
Yes,
to 1200 is a normal SVR. This one's like higher.
Okay.
It's a lot more vascular resistance. Cardiac index is under. POP is high. So heavy preload. Like your cardiac output, I think this one's like 2 to 4. If I'm being accurate. And they have cardiac index and output like side to side.
What's PAOP?
Pulmonary artery occlusive pressure.
What does that mean?
So that's how they measure to tell if somebody has too much fluid status in the preload so that it's backing up. Like they're saying like essentially like you're gonna saturate their lungs if it's too high. Like it's already elevated. So you wouldn't want to give this person fluid.
Is it like a wedge pressure?
Yeah, wedge pressure. They call it PAOP/wedge. You can call it a POP or a wedge. And then SVO2 is the cellular level of like utilization of oxygen. So a normal is 65 to 75%. And if you have less than, it means your cells are overutilizing, meaning it's using up a lot more than what's expected. And if it's like a higher percentage, it means that your cells aren't using enough, and that's usually in septic shock.
Wait, what's the normal cardiac index again?
I think it's like 2 to 4. I don't remember exactly, I'm not gonna lie, but I think it's 2 to 4.
Okay.
Let me go back. I'm sure it told me at some point. I could be completely wrong. It's actually 2.5 to 3.5. So, I mean, I was close. I said 2 to 4, 2.5 to 3.5. So, and then in the same like boat, they have cardiac output. That's 4 to 6. So this one you wouldn't give fluid because they're already like overloaded. They need an increase in squeeze. So you're going to use your inotrope. You're not going to use levo. Levo, that's primary for sepsis. And then levo is going to cause more SVR. So you want to use dobutamine. You don't want to increase the afterload because it's already kind of high. So that's why dobutamine.
Makes sense to me. Yeah, we don't deal with these numbers.
Yeah, to be honest, Skitch, I was just explaining to them, I don't deal with these numbers normally. So this is also frustrating for me. It's giving me a headache already. Just this section alone.
Big. Normal is 8 to 12, so that is very high. Our SVO2 is low. Normal is 65 to 75%, so we'll keep that in our back pocket. And then our SVR is high as well. It's 1820. This is elevated, as the normal is 900 to 1200. So every single one of our values is out of range. What are we going to do here? Like we just discussed, we're looking at the cardiac index, we're looking at the preload. This patient is overloaded, and it means that they need squeeze. So just to double check to make sure that all of our other answers are wrong, well, we just talked about how this patient is overloaded, so we're not going to give them fluids because they're already drowning. We're not going to drown them more. That eliminates
What's up, Phildo
C.
Baggins?
Choice A is norepinephrine, a pressor. What do pressors do? They vasoconstrict, but looking at our afterload of 1820, we are already super vasoconstricted. We're not going to increase the workload of the heart, so we're probably not going to choose that. And that will also eliminate option D because, again, we're not increasing preload. So that leaves B, which is the answer that we chose in the first place. Question number 4. Afterload is increased in all of the following except A, cardiogenic shock, B, heart failure, C, anaphylactic shock, or D, hypovolemic shock.
Well, if afterload is increased, it's not hypovolemic. I don't remember if it's anaphylactic. I think it's cardiogenic.
It's an accept question.
Oh, shit. Skip. Kill me.
Ashley.
What? What?
Promise me you'll read the questions carefully on your exam.
Are you noticing a pattern here?
Yes. Like, you know the answer, but you're not reading the question. I don't know what the answer is, to be honest.
So heart failure, it would be elevated. Okay, so we're asking in reverse. Okay, sorry. Hypovolemic is not it. Because afterload would be decreased. Cardiogenic would not be because the afterload would be increased. heart failure, I think the afterload would be increased.
So I mean,
Maybe.
cardiogenic and heart failure are the same thing.
So, all right, so it's C. There you go.
Wait, but I thought you said afterload isn't increasing hypovolemic shock.
Wait, isn't. Is? Wait, what did I say?
I thought you said it isn't. Is it?
Hypovolemic preload is decreased. Preload is decreased. Let me I have to think it through. Hold on. No, because you'd be dilated. And after, like, for hypovolemic as well. So your preload and afterload would be decreased.
But dilated is different than hypovolemic.
Well, I know that.
Because dilated is distributive, which is anaphylactic.
Hold on, I'm thinking about it. I'm going with, yeah, I'm still going with anaphylactic. Because it like,
right.
A and B are one
Instrument
and the
on the
same.
Bottom right.
You
What?
just sounded like you were getting to the answer with faulty logic.
Yeah, I understand what you mean. I told you this wasn't my strongest suit. I'm doing my best here. But I think it's anaphylactic. I know for a fact it's not A and B.
I think so too, because I was thinking about it. I was like, because you have cardiogenic, distributive, hypovolemic, and I was like, it makes sense. Distributive shock is you basically have no vascular resistance, and that's why you're in shock.
I was asking, what's the thing in the bottom right on your current slide? Is that a central line kit?
No. No,
Is
I don't know what the
it,
fuck that is.
IV?
I don't know. No, that looks like, is that a pulmonary artery? Like, I don't know what that is. That's something used to determine and measure something with, like, the PO2 or PV or something. Something I don't deal with. Something I don't deal with. But that's not a central line. That's not CVP. That's not... I don't know. Skitch, you got it? Aw, see you, Mad Max. Thank you.
No, I don't know what it is either.
You said a pick line? It's not a pick line.
I was like, I don't think that's a pick line.
It is not. None of that makes
It looks
sense.
like it has two ends. Like the right end is wherever it goes.
It's
and
not a
then
Foley
the
either.
left end.
JC, how do you get all these other ones correct but not this one? What you Googling over there?
He's probably trolling us.
Probably.
And the
He said he's
answer here
asking
is
Alexa.
C.
No, you guys are wrong. I am
Anaphylactic
not.
shock. And why
It's
is that?
probably a
So in
swan, but I
anaphylactic
was like, I
shock,
thought a
there is
swan only had,
massive
like, 1 or 2 lumens, so I don't think it had
vasodilation
that many.
due to the histamine release. So those vessels are dilated, they are open, and the resistance of the blood that's pumping out is going to be
Or is that a pacer?
low.
I
In
was like, I see
cardiogenic
things that
shock,
look like
heart
maybe they're
failure, and
electrical.
hypovolemic shock, the afterload will
There's
be
also,
high
like, a
because of
syringe on there,
compensatory
isn't there?
mechanisms.
Mm-hmm.
Anaphylactic shock occurs due to an allergic reaction and an extreme histamine release response.
That's right, everything drops.
So this histamine release results in massive vasodilation,
Everything.
increased
That's right.
capillary permeability, and decreased cardiac output, which all result in hypotension. On the respiratory side, the histamine release triggers bronchospasm and laryngeal edema.
See, this whole time, JC, I thought you knew this shit.
This is the one shock state where all of the arrows are pointing in the same direction.
Look
And
up
they
a
are
bit.
all
That's exactly
pointing
what he said. He
down.
said anaphylactic shock.
So as
histamine
far as
release
our
opens
treatment
up
goes,
everything.
we are going to remove the offensive agent if possible, and we're going to monitor the airway. It is always about ABC, airway, breathing, circulation. So monitor your airway, remove the offensive agent, and the first medication you're going to give is 0.3 milligrams of epinephrine, which is going to be a 1 in 1,000 strength in the thigh. Second line medications are going to be diphenhydramine, 25 to 50 milligrams, either IV, IM, or PO. Generally
Steroids and
preferable to
beta-2
give IV.
agonists.
Steroids are going to be included in second line treatment,
PNPs,
as well
what's
as an
that?
inhaled B2 agonist.
PNPs.
You can give inhaled racemic epinephrine
I do
or the B2
PNPs.
agonists such as albuterol
I'm the
to help
one you guys
decrease that
hate. Wait, what?
bronchospasm and open up the airways. And lastly, since these patients will
Oh.
have a decreased preload from the capillary leak, volume
Wait, what did you get
resuscitation
your
is
degree
going
in,
to be
dude?
very important for these patients. Question number 5. A patient presented to the ED with a history of aching and fever for
Here you go, Sketch. They presented in the DED. You better know it. The history of aching fever for 2 days. Patient was hypotensive, 80 to 60, non-responsive to a bolus of 30 per kg of normal saline with a pulmonary artery catheter was inserted. Oh my gosh, hold on. All right, with a PAP, pulmonary artery pressure of 41 over 18, that's high. Should be 25 over 10. CVP of 14. I think that should be like 2 to 8 or something like that. So it's high. So POP is elevated. So that's not the problem. Cardiac
Listen,
output.
Once they said PA catheter, I'm like, this is an ICU patient. Call the intensivist.
SPR is high.
So Skitch, is this stuff you originally had to learn and it's just you haven't used it and so you didn't have to, or is it different because you were studying to be like an ER doc?
I think we studied it at some point, but it's definitely not in the scope of emergency medicine. Like
No to
we would
B
not
and
be
C.
emergency medicine boards.
No to D.
That makes sense.
Emergent pericardiocentesis?
And that would be if you think the patient is cardiac tamponade, so they have like an obstructive shock.
They're not responding to fluids. I wouldn't give epi though. Like, their vascular resistance is high. I mean, their cardiac output isn't really that. I mean, it's slightly under, right? What I said, the cardiac index was 2.5 to 2.5 to 3.5, and what was the cardiac output was? Ugh, fuck me.
We said 4 to 6.
So it is under. So I mean, it's got pressure from that. It's not a fluid problem. Vascular resistance is just going to put more pressure on the heart, so your output's going to decrease. Everything else is, your CVP's high, your PAP's high, your PAOP's high, your systemic vascular resistance high. I'm thinking emergent pericardiocentesis.
Not C.
Yeah.
I think if your central venous pressure is 14, that to me is telling me that you have quite a bit of preload.
Yeah.
So I don't know if it's the fluids.
Right.
And then I was thinking, like, how do you get your cardiac output up? And I was like, norepi really wouldn't do it.
No.
So I'm like, is this an obstructive shock? But that doesn't fit with the history. Aching and fever for 2 days? Like, I'm thinking like sepsis.
Itch. We're not on the same page.
Well, if we say emergent pericardiocentesis, we get to stab a big needle in someone's heart, so let's do that.
Wait, why don't you want to go with it though?
The history portion just doesn't make sense. Aching and fever for 2 days? Like, that's infection, that's sepsis, which would be distributive shock.
I
You
mean,
wanna
is
get
it
cardiac
always?
tamponade.
Is it always though?
But how would you get cardiac tamponade?
Just
But I think
saying.
numbers-wise, it doesn't make sense. So I'm putting less stock in the presentation and more stock in the numbers.
That's
to
what I'm going
where
with.
I think numbers-wise, I think it makes more sense. Maybe this is obstructive, but I don't know what the obstructive picture looks like.
Fuck it. Going A. Full
2
sending.
days. The patient was hypotensive to
full
80/60 and not responsive to a bolus of 30 milligram per kilogram 0.9 normal saline. A PA catheter was inserted. Your hemodynamic values include a PaOP of 41/18, CVP of 14, PaOP of 16, cardiac output of 2.0, and an SVR of 1800. Which of the following treatments would the nurse anticipate? A. Emergent pericardiocentesis. B. Norepinephrine. C. Antibiotics. Or
Ash,
D.
My
I
bad.
need them to hurry
Aggressive
up.
fluid resuscitation.
You need what?
I need them to hurry up.
Why?
He's about to start a match.
E
Skidge.
And the answer here is
We're just sitting here on this
A.
slide.
Emergent pericarditis.
Yeah, she's not really. To be fair,
Now,
But
this
you're-
question
you're
is
kinda
more
just making him sit
challenging
here.
in that the usual signs of cardiac tamponade.
He's been
which
eating.
are
I
your
thought that's what
bulging
he
neck
was doing.
veins, muffled
I was
heart
right,
sounds,
BT
low
dubs.
he takes like 5 hours to eat and does other stuff while he eats.
I was not, and also, we were not sitting on this slide forever. I was asking questions. You were working through it. I wasn't going to fast forward while you were working through it.
mediastinum and pulsus
Ash, while you were
paradoxus
on the
are
slide,
not
I
provided.
left, went
However,
poop,
this patient is
came
presenting
back,
with cardiac
worked a
tamponade
little
as
on the
evidenced
rule book.
by the equilibration of CVP, PAD,
So you've
and
been on it for a little
PaOP
bit.
within 5 millimeters of
But then
mercury
we
of one
decided,
another.
and there was like a
as well
solid
as the
10
narrowing
seconds where we were
pulse
just sitting there
pressure.
on that slide.
10 seconds
Question
must be
number
just
6.
killing. All right, patient with an
What is that?
inferior wall MI develops signs of right ventricular infarction with a right ventricular failure. Which hemodynamic parameter would be most consistent with right ventricle failure?
I got nothing on the path. But it should have
I
an
guess it's-
elevated CVP.
So yeah, that's what
guess
I'm
it's
trying to
C.
look at, but I'm working through the rest. So pulmonary artery pressure, I mean, that one's almost normal. 25/10. PaOP should be 2 to 8. Which one are you leaning towards? And for what reason?
I like D because D is the 4th letter of the alphabet, which means it's green, and green is my favorite color. 16 divided by 4 is also 4, so therefore it's double.
All right, yeah. I mean, well, they did say they would be
Patients
drastically
with an
off. It wouldn't be
inferior wall
close.
and
It would
eye
be
develop
drastically off.
sign of right ventricular infarction with right ventricular failure. Which hemodynamic parameters would be most consistent with RV failure?
But I don't understand what the
A,
other numbers
a
mean. I
PAP
just
of
understand
53 over
CVP.
22, PAOP of 16, and CVP of 12. B, a
I mean,
PAP
POP and
of
PAP
32
would
over
be more
20,
so managing the
PAOP
left,
of
I think.
14, and
CVP
CVP
would
of
more
8.
so the right.
C, a PAP of 48 over 28, PAOP of 14, and
So those
CVP
being
of
slightly
8.
elevated.
Or D, a PAP of 26 over 12, PAOP of 10, and CVP of 16.
Yeah. It's D. I just saw.
D for duck.
There we go.
D, a PAP
That
of
was a
26 over
5 seconds
12,
that we just
PAOP
wasted
of
there.
10, and
God damn.
CVP
Well, because she
of
was taking forever.
16.
I just skipped it.
So if only the right ventricle
Exactly,
is
that's
failing,
what you
where
should
is it
do,
going to
just
back
skip
up?
ahead.
Okay.
The right atrium. So that the right atrium pressure, or the CVP, is going to be grossly elevated. And it is in A and D. But the wedge is going
God,
to be
fuck this
normal
printer.
since we're not dealing with any left-sided problems in
That's
this
right. 8 to
scenario.
12, I think,
So
is
we
the
can
wedge.
eliminate A, and our answer here is D. Question number 7.
All right, question number
You are-
7. Pausing. You are caring for a patient in cardiogenic shock after an anterior wall MI. You note the following hemodynamic parameters: heart rate 122, blood pressure 86 over 44 with a MAP of 58, respiratory rate 22, O2 sat of 94. Your cardiac index is 1.8, so it is normal. Your CVP is 14, so it's slightly high. You have a pulmonary artery pressure that is high of 56 over 24. You have a PaOP of 18, which is high. You have an SVO2, which is low, of 46, and an SVR of 1675, which is high. Which of the following would be the most appropriate therapy at this point? So your output is enough. That's not the problem. You have plenty in your preload.
I think Skitch is
Sister
exempt for this
Best
question, right? Because it's not an ED.
It really isn't.
Is that why you're
learning?
Is that why you're just
I'm
blocking
putting
me
Band-Aids
out?
I'm just putting band-aids on, but I can tell you just based off the first part of the question, they're asking about
Band-Aids on.
cardiac shock.
They're asking about what? Sorry.
Skitch, are you okay? Why are you putting band-aids on?
Cardiogenic shock.
Yeah. That's what they said.
Decent O2 stat though. Bit low.
It's fine. Not too worried about that.
Hey, Ash.
Yeah.
I just want you to know I'm about to take this printer and beat the living hell out of it with a hammer. Just thought you should.
Oh, well, don't do that. Alright, well, blood pressure. I'm not giving
That's pissing me
Lasix.
off.
And they don't need a milrinone drip, so we're gonna go ahead and eliminate B. B is for squeeze, milrinone, or milrinone's for squeeze. Lasix will pull your pressure and your preload. Let's see. Nitro is a preload. Dopamine. I'm trying to think. Is dopamine's not like? CVP's elevated. I don't know if I want to give another fluid bolus for that. I mean, I want to pull off fluid. I don't want to give more fluid. I want to pull off fluid, but I can't because their blood pressure. So, D? Sketch? I'm not
That
giving
makes the
A or
most
B.
sense.
I'm going with
I
D.
don't understand. I don't understand these numbers, but that makes sense for acute heart failure.
So-
basically,
So their wedge
Cardiogenic.
pressure's elevated. We're gonna cause we're gonna saturate their lungs, right? Their CVP is elevated, so their preload's elevated. I don't want to drop their preload with a beta blocker. Their blood pressure's not gonna be able to handle that. I don't want a fluid bolus because I'm gonna put more fluid on them. I don't want to give a contractility type medication like milrinone for squeeze because their cardiac index is normal. Epinephrine, I'd want to diurese them, but I can't diurese them safely because their blood pressure, so I'd want to boost it with norepi and I think dobutamine. I mean, I don't know if I'd go straight to dobutamine, but I would do.
their cardiac index is not normal.
It's a cardiac index I thought was 1.5 to 2 or 3.5.
2.5 to 3.5.
2.5. Oh, it's low. So yeah, dobutamine would help with that.
And then a beta blocker wouldn't affect your preload. It would affect contractility if it's
That's
beta
right.
1, or afterload if it's beta
I
2.
keep saying beta blockers affect the preload. I need to get that out of my head. Okay, so I'm exiting them out, but for the wrong reasons.
Correct.
Sketch is like you're on the right track for the wrong reason. Okay, but I mean, norepi makes sense. Dobutamine makes sense because of cardiac index. I don't know why I thought the normal was. Bless me.
And
Lasix
then
makes sense to pull off fluid because CVP, PA, and PaOP.
B doesn't make sense because if you're giving nitroprusside, that's to drop
The
Preload.
preload. Yeah.
it's venodilatory, and then you're giving fluid, so that's
Yeah.
you're
Then you're
contradicting
overloading.
yourself.
Yeah.
So that doesn't make any sense.
Yeah.
And then if your cardiac index is already low, then you don't need a beta blocker. But I believe
Right.
dopamine does increase contractility, so I think otherwise you
think it does.
probably could use dopamine, but generally I think I see dobutamine used more.
Dopamine they use more so in cases of pressure where the heart rate is a little bit more unstable. At least that's what I've seen in the ICU. And dobutamine is the go-to when they don't use milrinone. They'll pick either milrinone. They usually use milrinone first and foremost in my facility. I've occasionally seen dobutamine, but primary milrinone. Yeah, D's the best.
We're caring for a patient in
It's D,
cardiogenic
'cause we
shock
like
after
D.
letters. Heart rate of 1, a cardiac index of pressure of SVO
does.
would be the shock. They are hypotensive with a low map. They're tachycardic. First things first, we're looking at our cardiac index. It is 1.8. Do we need to do something?
Shut up,
Still on this
JC.
Yes,
question?
we do, since it's lower than 2.5.
Actually,
Next,
That's-
we are looking at our
that was
preload
10
numbers.
seconds.
So our CVP is
10
14,
seconds, 10 whole
which is
seconds that
high,
we waited.
and our PaOP
TJ.
is 18.
Did we
which is
really
also
wait
high.
10 whole seconds? I sped through all of that after we figured it out.
Skit, she owes you a second Tinkerbell movie.
Does this patient need
And a trip
fluid?
to Disneyland.
No, absolutely not. Their preload
I
says
wouldn't
that
go
they
that
are
far.
overloaded.
Tinkerbell movie doesn't
So
cost
let's
anything.
eliminate our answer choices that
You
have
know,
fluid
they
in them.
came up with
Been
a...
3
That's
years
gonna be
ago.
A, and that's going to
the
be
Tinkerbell,
C. The only difference
film?
between the two is that
More than
3
B
years
has
ago.
vasopressin as its pressor,
You're saying
and
when it
D
came out?
has norepinephrine
No,
as its
like
pressor.
when she promised.
Which one of
it.
these are you going
That
to
has not been that
choose?
long.
No, it was about a year ago.
Dude, it hasn't
Yeah.
even been a year.
No, it wasn't that long ago.
It was like, it
Actually,
was
probably,
like
6 months ago.
6
isn't
months.
it?
Yeah, I was about to say. Good
Because we
lord,
watched-
y'all are way off. Y'all's time concept is terrible.
Listen,
Talking about
2025
3 years, a year. Come on now.
2025 has been a
I'm
really
pretty
long
sure it's been a year.
It is not, dude, because we made this promise after we went to Disney last year, and we went to Disney
I
a
think it was in
month from now,
October.
so it was late.
Also, when are we going back?
This is all
Sketch,
Sketch
it's
cares about.
expensive.
I'm trying to
But we need-
figure what Sketch.
But we need to do this. I need it for my survival.
Well, I need money for my survival, Sketch. So I mean, you know,
Damn.
Have you decided which Disney?
Zach. No, that's been the
I
biggest
mean, if we're going
thing.
to Florida, there's no way. I have a plane phobia, so that's the other issue. Like,
Zach has a similar phobia to what I have when it comes to planes, only he's, I think, probably worse.
yeah, I'd get arrested for having a panic attack on a plane.
You'd have to, Sketch, this is when you just prescribe the man some, like, fucking Valium and knock his ass out for the plane ride.
I mean,
You
yeah,
don't
if
have
you want
to
to knock my ass out, in which case, he has to meet me at the airport so that you can watch over an unconscious me.
You know how much trouble I would get in for that?
And Sketch is like, I don't
Only
want to
a
lose my
little trouble.
license. Well, if he has an
No,
actual
Sketch,
anxiety disorder.
Well, I can just see my actual doctor for that, because they've recommended that for plane flights before.
I
Aw,
think the main thing is like if you're actually taking that much to where you're knocked out, you do need to monitor, and there's just no way to do that on the plane.
just give him like 5s. He'll be fine.
But that's not going to knock him out, is the issue.
Yeah, but if he's not used to it
How
and he's
much knock-
naive to it, it might touch him.
How
I
much
mean-
knocks you out?
It'll probably help, but
Ash, how much Valium knocks you out?
I don't know. We don't really use Valium too often, to be fair. I mostly
would
use
guess-
like
Ah.
Ativan and like AKA lorazepam. Sorry, what
I would
Sketch?
say the bare minimum, probably 10,
Yeah.
possibly more.
Alright, so 20 it is.
I think if you had 20, I would be supporting your airway and giving you oxygen.
Oh, damn, okay. So it goes from you're a little eepy to you might die very quickly.
Yeah.
Yes,
could
we're
give 'em the
discussing drugging
military.
Zach Sentinel.
You could give him the military grade stuff. Then he could be like a sniper
Yeah,
at
that-
the same time.
Can
Yeah,
absolutely.
there we go.
Free Radical said terrible time for a plane phobia.
That is true.
Say what?
I said that is true.
Norepinephrine.
Okay, we're gonna fast
Question
forward
number
this.
8.
All right. Question number 8. Which medications are most often prescribed for anaphylaxis after initial therapy with IM epi? So I would say
Ooh, that's an
antihistamines and corticosteroids.
You
A.
are correct.
Hey, I was able to answer one.
Which
you go.
medications
Honestly,
are
the
most
steroids
often
really
prescribed
don't
for
do
anaphylaxis?
anything. If it's true anaphylaxis, it doesn't help. But we do it anyway because it makes us feel better.
I'm gonna have to print this out at FedEx. Fuck my life.
You're
Fuck.
fired, Sketch.
Fuck.
After initial antihistamines and antibiotics.
Actually, I feel like we've been waiting 5 seconds.
Antihistamine
God
will
damn
help
it,
suppressors
Skitch.
anatripsin. And question number 9.
I feel like you're doing this just to
I'm-
troll me now.
I'm just enjoying giving you a hard time about this. Thanks for letting me give you a hard time about it, actually. I appreciate it.
Power of friendship.
I just saw your reaction on
Hard.
screen.
pulmonary artery catheter is inserted and reveals the following. Your cardiac index is 1.9.
Wait, what was the way you said that?
Your CVP is 3. Okay, I'm going with fluids almost at this point. Hold on, give me a second. Just out the rip. Give me a second. I have to think about this. Phenylephrine, that's neosynephrine, right?
Correct.
Okay. We don't use neosynephrine too often.
Is it too?
I mean, the
new?
cardiac index is low, but everything is low. Maybe fluids? Fluids. It's either fluids or it's D. But I want to go with fluids because the CVP is low, PaOP is low, SVO2 is low, cardiac index is also low.
Hello?
When do you give dopamine?
Everyone have a
It's
good time.
pressure support, but it also helps with contractility, I think, a little bit. Doesn't it, Skitch? Dopamine is one that's a little bit more. I'm trying to think of the word. It's a little bit more stable,
Meech?
like for our
Meech.
unstable cardiac patients. We don't use it often. We really don't. Dopamine.
Aren't
Yeah.
there like a bunch of like bad side effects that can happen with it?
Huh?
Aren't there like a bunch of side effects that can happen if you give it to people? Is that why, or?
I honestly don't know. I just know that like it's not our first line for pressors unless our pressors are really causing problems. Like if someone's refractory to like Levophed or like shoots their heart rate up way too high with epi, we'll try dopamine.
I mean,
Jace-
this one sounds
JC,
like
it's all
trauma.
low.
It's
So
trauma, so what they're getting at is going to be hemorrhagic shock, which is
So
hypovolemic shock.
yeah, so fluids.
So I do believe the answer is fluids, but
Thank you.
I don't understand the numbers. I'm just going off of the stem.
I'm going with fluids.
A 56-year-old patient C would include and cardiac index first.
There we
It
go.
is low, CVP of low index, low preload. They need fluid.
Okay. Which one of the following sets of hemodynamic data is associated with cardiogenic shock?
B.
I also like B.
Also, don't listen to me. I have no idea. I don't even know what these numbers mean, to be honest.
Oh wait,
All right,
but it's super low
Skitch.
on the other end. A is interesting too.
I'm leaning at A because I'm looking at the cardiac index. But then, hold on. I'm either looking
What
at A
is
or B. It's A or B. 2.5 to 4, 2.5 to 3.5 is normal.
I think A.
Hold on, let me read through it just one more time. Cardiogenic
isn't
shock
that a
usually
super-
decreases your cardiac index, doesn't it, Skitch? Your cardiac output decreases with cardiogenic shock?
That would be the definition of cardiogenic shock.
Show would be B.
That's where my eye went to initially, but also look at the
A.
CVP.
It's low.
Which I feel like in cardiogenic shock,
Actually-
don't you usually get their CVP?
The CVP is, I think, normal, actually.
Is it?
Yeah.
Because
Yeah,
basically,
CVP is
cardiogenic
normal.
shock is basically like acute heart failure.
Right.
You can't pump out.
Right.
So everything should back up.
Skitch. I'm just saying CVP, POP, SVR is high. CVP I think is normal, man. Cardiac index is low, which is the main thing I've been looking at.
I was like, the odd part is like, see, the cardiac index is like low end of normal. So the only one where the cardiac index is actually
It's drastic.
low is B. But
Well, yeah.
I feel like you would have an elevated CVP, and really the only place you have that is C. Also, look, I posted a thing about dopamine in the chat.
You did, where is it?
In the chat.
Dopamine is a precursor for norepinephrine, epinephrine, which acts in dose-dependent fashion on dopaminergic receptors and alpha and beta receptors. At low doses, dopamine receptors activate the renal artery vasodilation. At higher concentrations, it activates on contractility. Okay. But cardiac
Skitch, I don't
index,
see
like we were
anything in
saying,
the
our
chat.
main focus, Skitch, with cardio index was the fact that it would be low and cardiogenic. So I don't think it matters about any of the rest of it. Because if you just keep going back to just the cardiac output / index itself, everything else would be irrelevant. Look at the SVR and BP. Dude, the BP is the same. The SVR is elevated in 3 of the 4. And it's under in A.
I think B probably is the best answer.
See, I don't like that shit, because I just don't like it. Yeah.
Question number 10.
We're also going to go back and
Which
we're going to
of the
see what the
following
up and
sets
down
of
said.
hemodynamic data is associated with cardiogenic shock? A BP of 78/42, heart rate of 120, CVP of 2,
Hey, guitar
PAOP
player.
of 4, SVR of 453, and cardiac index of 5.5. B, a blood pressure of 78/42, index of PAOP of
Let's see.
The answer here is B. In cardiogenic shock, remember, we have blood backing up into the left ventricle and thus into the lungs. This leads to a high PaOP and wet lungs. This should be a giveaway to the answer since B is the only one with a high PaOP. They will also have a low cardiac index and a high SVR because it's compensating for that low blood pressure. So B is going to be our answer here. Question number 11. A patient presents to the ER 1 week, status post
JC Boak
right
is
hip
right. The PaOP should be really high. And that's the only one with a really high PaOP.
Yeah. I mean, but either way, the cardiac index / output is going to be low. It's never going to be high. So the other one would be wrong regardless. It being high isn't correct.
My answer. Teardrops.
So, I mean, you can say it's all based off the PaOP, but it doesn't matter. Like, the number should go in one direction. There's an actual, like, chart for that. And cardiac index is a decrease in cardiac output, an increase in preload, increase afterload, and decrease in SVO, I think. Yeah. Well, you're going with the highest also because they did say there was a differential. They did say that it would be drastically different. They would pick something like, just because the scales vary slightly, from book to book and from research and whatever. So, a patient presents to the ER 1 week, status post right hip arthroplasty. She has a MAP of 58 millimeters of mercury after 2 liters of normal saline. The heart rate is 121, the respiratory is 34, and her temperature is high. She is at 39.3 Celsius. Her lungs are clear, skin is warm and dry. White blood cell count is 20,000. She is in septic shock, dude.
She's probably fine. Probably anxiety.
Dude, she's in septic. Like, as soon as they, like, lungs clear, skin is warm, I'm like, okay, we're set. We're in early stage septic shock.
Yeah, she's
Patient
sepsis.
is.
It's just like she's fine. It's a flesh wound.
It's a flesh wound. Patient does not have a pulmonary artery catheter. If she did, what SVR should the nurse anticipate this patient would have?
Ash, what's a pulmonary catheter?
Pulmonary artery catheter? It's to
Yeah, what is that?
measure the pulmonary artery pressure.
Does that go like into the vein?
It is a
No.
tube that goes usually into one of the big veins, usually in the neck, and they go all the way to the heart.
And then in, and they float it.
And it just sits there in the big ass in the big ass vein in the big I forget what it's called, in the large vein, in the you just stick it in a large vein and it's chill. Like, it's good.
Yep. And then sometimes you advance it into the heart, and then you block off the blood vessels on purpose so you can measure the pressure.
All right. What should the systemic vascular resistance, the afterload, be for a patient who is in septic shock?
What is your answer, my child?
Do I answer first?
Go for it.
I'm gonna
A or C?
say A.
I can't remember.
Wouldn't it be high because you got like stuff clogging up your
No,
vascular?
no. I mean, it would be high if it was clamping down. Like you're talking about vascular resistance, the clamp.
The clamp.
I
Yeah,
mean,
so
I think it would
wouldn't
be
a
dilated in
high
early
number?
stages. Wouldn't it be dilated? Your after, like, or I mean, wouldn't your afterload be low? I'm between A and C. I really don't remember if it's either too high or too low. It's not gonna be B or D.
So, let's think about this.
Please, let's do.
You said this is septic shock,
Yes.
correct?
Yes.
Correct.
What class of shock does septic shock fall under?
Cardiogenic?
It's a distribution.
Yes.
Distributive.
Oh, now I'm picking up.
Cardiogenic means that your heart doesn't function properly. It's not squeezing well, and then so you can't maintain a blood pressure because your heart can't squeeze.
Yeah,
In
which this
sepsis
is
and
not.
infection, your
Yeah.
heart usually squeezes fine,
Yeah.
or at least it's not really affected. The issue is that you have an infection that's causing a lot of inflammatory response.
So
as
permeability,
a
increased
result-
permeability.
I mean, you get that, but you also get vasodilation.
So
your
it would
blood
be
vessels
550.
dilate. And if you have bigger blood vessels, then you have
Your
a lower
resistance
pressure.
is low?
Yes.
The resistance, yeah, because it's basically that's a measure of how tight your blood vessels are, And so if they're smaller, they're more constricted, then the muscles are causing it to squeeze tighter, essentially, is kind of how you can think about it. So you have a higher resistance. And if they're
Do
all
you
loosey
take
goosey,
do you take the measurement when you're looking for like an SVR in multiple places?
I don't actually know how they calculate an SVR.
I'm
never
not
done
gonna
it for-
lie. Me neither. So it's 550 because it's that dilation, which I guess makes sense since the first line is pressors always on a septic shock patient for clamp down. Right?
Well, fluids, usually.
Yeah, but primarily like in a septic shock patient. Obviously first line is that, but most likely the way I'm thinking of this is in terms of like you've already given the basic fluid boluses. The patient's sick. They're not responding. They keep dropping.
Correct.
So
Correct.
they need help with the clamp.
Correct.
Arthroplasty. She has a map of 50. So for this question, we have to put the picture together.
Their blood vessels
This
are being
patient,
silly
with all of her
gooses and being
symptoms,
very
is presenting.
loosey-goosey.
Yeah, Ken, we went over the chart at the beginning where they were talking about the SVR and all of that for the normal. They said sometimes some of the books will say 900 to 1200, but she was going with 800 to 1200, but her whole point was like, regardless, if you have a question in the exam, they're going to make it drastically one way or the other. What they're looking for, their focal point, they'll make it drastic so there won't be any confusion.
And the other thing is if you have mid-range numbers, it doesn't make sense because you have multiple kind of mid-range, or like you have a mid-range, a couple high range, only one low range. And if it's going to be abnormal, then it has to be the one that's on that side of the abnormal scale.
Yeah, you're not going to pick something that's like just within the parameter. Like they're looking for a change, Ken, like usually a drastic change. One swing or the other.
With septic shock following her hip arthroplasty. If we
Aww,
remember our shock table,
DJ.
a patient in septic shock is going to have a
great with medical
decreased
knowledge,
afterload
but I'm great at taking tests.
due to the massive inflammatory response, which is going to cause vasodilation, and that's going to decrease the resistance of the blood pumping out, so you will have a decreased
Skitch, I think you're
SVR.
pretty good with the knowledge.
Yeah, I think he doesn't.
Number 12.
I don't think he gives himself a lot of
Which
credit.
is a compensatory mechanism of
Thanks, I appreciate it.
Which is a compensatory mechanism of hemorrhagic shock.
I understood half of that sentence.
All right, and can you give me 2 seconds? Real quick.
1.
God damn it.
Skitch, the other problem is if I meet up with Ash, she might finally strangle me. So is this test something regular nurses take? Just the position Ash wants, the CCRN?
So CCRN is critical care nursing. So she's working in the ICU. So she's basically already doing this, but sometimes they want you to get those extra certifications so that you can have more letters after your name and feel fancier. I think mostly I think if they get certified, they might pay her more, honestly. versus like it offers career advancement opportunity. But she wants to do cRNA, so honestly, I don't think this really matters. Like this hemodynamic stuff will absolutely make a difference for her, and if she's a cRNA, like she'll know this stuff inside and out far better than I do. But it's specific to critical care. But honestly, like even within critical care, you have different divisions. So like your general ICU nurse, I mean, they're probably not dealing with this stuff most of the time. Like these are going to be your cardiovascular ICU nurses that are really doing this. Also, I appreciate the 69 in there. I'm getting tired of typing.
What are you typing?
Ash said 2 seconds, so I typed 1, 2, but I'm still going. I'm now at 79.
You're typing this?
Yes. You
Please
should
tell
pull
me
up
you're
her-
not putting all of these in the group chat.
Oh, it's not in the group chat. It's in her public Twitch chat.
Okay, that's pretty funny. She's gonna come back and be like, why do I have so many messages? And they're all gonna be from you. Does she not have an auto mod?
I think she does, but it either doesn't count it as spam or because I'm a mod in here, it doesn't mod me.
Huh. Peter, you have unlimited power.
I'm glad you noticed.
How can the
Sentinel.
numbers go?
This is getting really tiring to type. And I'm probably a little bit off.
Did she say
'cause
what she was doing?
I don't know, but I hope she comes back soon for my sake, because I've committed to this at this point.
Committed to the bit.
See, this is why it takes me so long to eat, because then I'm doing stuff like this. Oh, I mistyped.
Listen, trolling Ash is a full-time. Uh-oh.
I typed 1,322 instead of 132.
Ooh.
And you can't go you can't go cheating there, Sketch. I mean, you might get there.
Watch. She's gonna come back in like
Alright, so
30 minutes.
I think she'll come back in 10. You're gonna be at like 600 when she comes back. Watch as she went to like Rita's ice cream.
Oh my god.
That would be so funny.
I did mistype
What the
another
fuck
one.
are you?
Oh,
What is happening?
Okay, there we go. There we go. Now I can stop.
What is
Thank
happening?
God you came back, actually. This is getting really tiring.
And on this day, Skitch counted to 152.
Skitch. Why are you
How many-
blowing
that's
up my
how many-
chat with bullshit?
That's how many seconds you were gone.
I respect the commitment. How long you were gone? Jesus Christ.
Yeah, she did
I
say
was
2
looking-
seconds, and she was gone 60 times longer.
Oh my
No.
god.
Well, I feel very betrayed. I have trust issues now.
Right? Now you have to take him to Disneyland, Ash.
Yeah, that's only fair.
Ah, my head. You're fired, Skitch.
Thanks, Ashley. I appreciate it. I've been looking forward to this for a very long time.
All right,
On
Skitch, are we
behalf
gonna
of the
answer this
Academy,
question?
I would like to thank Lost Girls and Z-Sock and Sentinel and Coach and Dom and Sociable and everyone else who was here in attendance for me to receive this firing. It's been a
Someone
great
mod the
honor.
mod. Trust me, I'm trying to mod the mod. '89 seems low for how many times she's fired people. I mean, that's fair. Skitch.
Yes.
Which is a compensatory
Is he still
mechanism of hemorrhagic shock?
A.
No, because dilate compensatory. So it's compensating for its loss. It's not going to dilate. That would be silly.
But you gotta explain why, Ashley. The people don't understand.
Okay, explaining.
Yeah.
Hemorrhagic shock means you're losing volume. You're hemorrhaging.
And what
So-
does hemorrhage mean?
Hemorrhage means to lose blood, usually.
Well, I know
You're
what hemorrhage
Where?
means. I'm dumb.
So you're
but I'm
in
not that
shock
dumb.
from the loss of volume from hemorrhaging. So compensatory means you're trying to compensate, and its mechanism to compensate would not be to dilate. That would drop its pressure even lower. You're already losing volume. And parasympathetic is your rest and digest. So that's going to relax everything. So that would do essentially the same thing. So you wouldn't want that. You wouldn't increase your fluid shift from capillaries to interstitial because you would lose volume that way too, so that would be silly. C is the most likely.
Yeah, because I think it will happen. You're gonna have fluid that shifts from the capillaries into the interstitial space because you have increased
And you've-
vascular resistance.
Yeah.
But it's not a compensatory mechanism, it's a byproduct.
Mhm.
Versus your renin-angiotensin system will compensate by trying to retain more fluid because you have a low blood pressure.
He said your mod job depends on this answer.
I'm also going with
C.
C.
Increased reabsorption of sodium and water.
Your RAS system.
So in
Look at me, I'm using
hemorrhagic
endocrine.
or
And I
hypovolemic
hate
shock,
endocrine.
compensatory mechanisms within the renal tubule cause
Look
the
at you
release of
using your
testosterone.
endocrine.
This results in an increase in reabsorption or retention of sodium and water and expansion.
Here we
So if
go.
what I just said in the last slide was a bunch of mumbo jumbo, let's look at this diagram and see if it will help. So in hemorrhagic or hypovolemic shock,
It's like
you
I
are
knew this
losing
slide was
fluid
coming.
and volume, and your body senses this fluid and volume loss. In order to compensate and maintain your blood pressure, it activates RAS, or the renin-angiotensin-aldosterone
So,
system.
Skitch, why do you hate
And this
endocrine?
activation of RAS results in two things.
It's
On the
very
left side here,
complex.
we have an increase
lot of
in renin
pathways.
secretion.
I like simple.
I like
So hand up,
simple.
patience.
So he doesn't
Yes.
like the renal system, and he doesn't like endocrine because there are a lot of biochem.
Oh, you know what I hate even more though?
Oh god.
Neuro pathways.
Oh yeah, neuro's kind of a
Is that
bitch,
even
but it's
something
fun.
You deal with? Wait, do you even deal with those though, Skitch?
I just
Stroke
tell
patients.
people, I don't think you're having a stroke. This doesn't fit a stroke-like pattern. But if you're trying to localize
they
the
like that.
deficit, where like neurologists do that, where they'll like think about this, and they'll like think about where in the pathway you could get that lesion. Holy crap! I remember watching a neurologist do that in medical school.
And it was impressive, but it was also very, very painful for me. And that's when I knew I did not want to do neurology.
Well, you just
And on the
think
right
about how
side,
many
you have
parts of the brain there
aldosterone
are.
release. So pertain
Confusing.
And they're all
I
very
mean,
long.
there is a theory. I mean, there is a theory that it's the most complex thing in our universe. We're not certain, but like it might actually be more complex than anything else.
Listen,
Naturally
I
occurring, of
see-
course.
I see butt, I stick finger in butt.
pertaining to this particular question,
Skitch, I think you
the
would love Dark
aldosterone
Souls.
release
One of the most common
results
phrases
in
in that game
increase
is,
in sodium and
what was it,
water
Trifinger butthole?
retention, which is going to maintain your blood pressure in a
Like the
time of
Triforce.
losing fluid and volume.
So the reason
Question
why
number
Trifinger
13.
butthole exists
The difference
in Dark
between a
Souls
dopamine
is you could send messages to other players. Some of them could be helpful, like cliff ahead. But there was also like try this, like try is one of the words. And so people combined all the words to get Trifinger butthole because there was a guy in one of the games that was bent over with his ass sticking out. Like that's just how he happened to die. And so people were like, Trifinger butthole. And that just became a message that people said in all the Souls likes. So that's your bit of
Ashley.
Dark Souls knowledge for the day.
Ashley,
Yes,
I posted this earlier.
I already
Have you read
know.
it?
I already know. There's a renal and a cardiac like one. The renal's the lower one. The cardiac one's the higher one.
I'm gonna
So-
be honest, I don't remember Jack, but I'm gonna go with what you answer
Skitch,
because
I
you
just
sound very confident on this.
Skitch,
So
I just realized something, and Ashen, you are gonna hate me for it.
it's either B or C. What?
Do you not have a butthole?
You could call. No, you could call the renal system the GAP system.
What does that even mean?
I don't see how that applies.
I don't either.
Isn't the
Can I
renal, like,
fire him?
Isn't your butthole part of the renal system?
No, that's GI.
No.
Now,
Yeah.
if you
Whoops.
have
I take that back.
if you have a grade 4 vaginal tear, then it kind of is, because then your vagina and your urethra and your anus share the same hole.
That sounds horrible. Does that mean poop can come out there?
Yeah, it's one of the horrors of childbirth.
Oh my god. Oh my god. That is. Ugh.
Gotta make
So
room
Skitch,
for the
I'm not gonna
baby.
lie.
I can post it again. I still have it.
Were we
copy and
talking
pasted.
about dopamine or dobutamine?
We were talking about dopamine earlier.
Okay.
That was the one that I posted.
I'm just making sure. I don't remember the receptors though.
Here, I'll post. Do you want me to post it, or do you want to try?
You got this, Ash. I believe in ya. So, Skitch, are the receptors like the nerves that respond to this stuff being in?
Does the alpha receptors like handle?
They're not nerves, but they are a way for cells to communicate, or organs or things to communicate. Because basically what happens is the way your body signals, a lot of it is where you release some kind of chemical, which then
attaches to something called a receptor that's on an organ or on a cell, because every cell has its own environment and it has like a membrane around it.
Drip
So,
at 5 to 10 mics per
Stuff
kilogram
can't
per
just
minute.
float in nilly-willy.
B.
It
To
has
cause
to be
mics per
identified
kg
or has
greater
to
than
interact
10
with it.
mics and
And a
increase
receptor
afterload.
is kind of like a docking station for that particular signaling chemical.
Oh,
And
I have no
so-
idea, Ginger. I wasn't listening to him.
And the correct answer here is A.
Oh, I was
Dopamine
saying-
at
No,
5
was
to
asking
10
it,
mics per
what a
kilo per
receptor
minute
was.
stimulates the beta 1
But
receptors in
to
the
answer
heart
Ginger's
to
question,
increase
I was talking about a
contractility.
grade 4
Now I know that there are a
perineal
lot of words
laceration
on this page and
in
it is a little
childbirth.
tricky to digest, but in
Oh.
I
short,
kind of stretched it a little bit. The
mid-range
urethra probably doesn't
dopamine,
become
so
into the
that's going to
same
be
hole,
your
but it
dopamine
might.
at 5 to 10 mics per
If it's
kg,
really terrible,
stimulates the beta 1 receptors
multiple
in the
tears.
heart to increase contractility. And on the other hand,
but
high dose
receptor,
dopamine,
yeah,
so greater than 10
it's a
mics
way
per
for it
kg,
to
stimulates
signal
the alpha receptors in the arteries
and
to cause vasoconstriction and to
it's like a
increase
docking station to
afterload.
receive that specific signal because receptors have to be specific.
I've
They're like
included
puzzle
yet
pieces.
another chart, and this has some pressor.
That makes sense.
Oh god, here we go. These are the parts that fuck with me.
If only these.
There is no way I'm going to remember this.
Norepi acts on the alpha and beta 1 receptors, but not the beta 2. Phenylephrine is only alpha receptors. I'm not gonna lie, like, I'm gonna have to memorize it. I know beta 2 for bronchial just because of, like, beta 2 agonists, but, like, oh god, fuck me. This is a chart
Break
that
out
I
the
am too tired.
flashcards.
Dude, this is a chart that I'm too tired to kind of, like, deal with.
All right, so beta 2s, right?
Yes.
Now, beta 1, turn the beta a little bit on its side. So tilt it towards the left, and now the humps are kind of facing upwards, right?
Yes.
And then just kind of bring that straight portion of B outwards a little bit towards the left side. Then slide the 1 in there, and just picture a very lopsided heart, like you drew a heart, because it's on the heart. It acts on the heart. If you don't remember that, you'll remember that because I was really dumb, and now you're thinking, what the hell is Skitch talking about?
That's exactly my face. Were you looking at my face?
Yes, but
Ken.
also I used to teach in like undergraduate level classes, and one of the ways my students would remember things is that I have kind of odd ways of remembering things sometimes, and it's just the way my brain works and it makes sense to me, but it's very odd, and so it doesn't make sense to them, but because it's such an odd story, they'll be like, what the heck? And it'll be memorable because of that. So I'm hoping that that will be memorable for you.
So epinephrine is an alpha, like an alpha and beta 1 agonist for the most part, with a little bit of beta 2.
I think the
What's an
best way to
agonist?
think of epi is it works on all the receptors.
And so does dopamine and dobutamine, just a little bit less than. Dobutamine is primarily the heart, which is B1, which makes sense because dobutamine is usually used for contractility like milrinone. What's the difference between milrinone and dobutamine? They both handle contractility, except for it doesn't act on the vessels at all, I don't think.
I haven't used them enough to really understand the difference.
Okay. Milrinone, I want to say, doesn't have any impact on the blood vessels whatsoever. I think it's just a primary beta 1 in general. Dobutamine
But
is the only one that does somewhat.
as far as
agonist goes, to Zach's question,
Yeah.
when it acts on a receptor, it gets a signal at that receptor. An agonist basically is activating it. It's saying, yes, do the thing that is triggered by this. An antagonist will also interact with the receptor, but it'll tell that receptor, no,
Don't do this.
don't do the thing
Yeah.
that triggers.
Oh, interesting. Yeah, human body's complex.
Plus dobutamine 5 mics, so that's the renal one, and then the cardiac one is the greater than 10, which is why they have it listed for like greater than 10 mics is a beta 1. Right?
I was writing a response to free radicals. I didn't hear what you said.
What were you responding Jesus, what are words? What were you responding a response to?
Yes, an irradiated sickly patient is brought into the hospital. What do you do?
Oh, I remember asking that. You said irradiated, right?
Correct.
Irradiated. I think he's talking
Yeah,
about in the
wasn't
case
the
of
answer to
like
that.
blood products.
Oh, not like radiation.
I'm assuming that's what free radical is asking, is like a radiated patient.
Don't you have
Oh,
to isolate them?
Yeah, didn't you say?
yeah. When I think of it, I think of irradiated
Well,
blood
doesn't
products. Sorry.
it also depends on like when you find out, right? Because isn't there a chance you all have to be isolated too if you've all been exposed for a certain amount of time,
Yeah, which is why I said
or just
tell
exposed
them
period?
tell them to GTFO because they need to be decontaminated first before they can come in.
Wait, does that
I
mean if
don't
they're
know,
having
but
a
I'm
heart attack,
managing
you
their
won't
pain
treat
and
them?
I'm giving them fluids. Iodine will
Wait,
stable.
Skitch, is that
Iodine stabilizes the radiation in the thyroid, right? So it can't bind to the thyroid. Iodine binds, so the radiation can't bind to the receptors in the thyroid.
Wait, Skitch, what happens with like if someone's having a heart attack and you know they're irradiated, do you just kind of leave them? Like, this is a legit question. Like, what do you do?
You decontaminate them as best as you can first, and then you probably figure out how you protect yourself. But
Like, I guess what I'm asking is like if you're like, if for whatever reason, let's just say you know that this person is super radiated for whatever reason. Highly doubt that would happen, but like, you know, if treating them is going to expose you to who knows how much radiation, because is that two people potentially die? So that's why I'm wondering, is it like you just kind of let them go?
I think if I know that like this is a lot of radiation and it's a dangerous level, I think the answer to that is yes, because one, if they have enough radiation to give us enough radiation for it to be dangerous to us, I think they're pretty much as good as dead, for one. And then two, I'm exposing a lot of other patients, staff, myself, to radiation. And then we're all going to need care.
It's got to be
So,
pretty rare
makes
though.
sense.
Like you run into
I think-
something like
I
that.
think if it's that
I don't know,
high,
he's given
then
a
I would say
specific-
yes.
He's given a very
Like, I
specific
would-
situation.
Like I would probably.
Yeah, it's not something likely. I'm just curious what the, you know.
I just don't know
I don't
where his mind
know-
went with picking that, like a radiated sickle cell. Like an
There's
irradiated
probably
sickle
a
cell
lot of,
patient. Why would they be getting irradiated anything? Are you just saying in the event that somebody had irradiated products because of, like, were they undergoing like chemo and radiation for any reason, like, and they just happen to be sickle cell? Yeah, no, you're good. I'm just, it's a very strange one. Because I'm thinking sickle cell crisis, a patient comes in. I mean, it's fluids and pain management. But if you're talking about a sickle cell, like a sickle cell with irradiated, like, I just keep going back to irradiated blood products. Like, irradiated blood products are usually given for patients who are undergoing chemo or, like, I think AML or something. Like, and supposedly it helps it prevent, like, was it, what's the name of the, grafts versus host disease. Like, you could give irradiated products for somebody who's at risk for that. We had one patient actually, like, last week with a grafts versus host disease, and that can be like a forever thing or like a temporary, or it could last, like, I mean, there's just no end to that. So I don't know. I guess I would want to know, like, what else, why were they irradiated?
Like what they were exposed. Are we?
Oh, it has nothing to do with the sickle cell patient.
Like
Okay. To be honest, I don't. To be honest with you, I don't have any radiated, like, patients who have, like, any indwelling radiated, like, what they call, like, beans or whatever. Like, they have these, like, little parts that they can put, like, radiated things, like, in people when they're receiving, like, you know.
What?
No, there's, like, these actual, like, little, I forgot what they're called, but they're like essentially little metal balls or something that, like, are radiated that you can put in somebody, and that's part of their treatment. And it will
That's
apply
something they can
radiation
do
to
to
a certain area. Yeah, it's an actual, like, thing. Or, like, were they, like, were they overall, like, treated, like... Right. Yeah, no. I know it's for cancer patients. I guess it's a little bit harder for me because I don't treat cancer patients. Don't get me wrong, I treat patients that have active cancer, but I don't give them chemo and I don't do radiation. I'm not a chemo or radiation nurse. Like, I'm not an oncology nurse. Like, I don't handle any of that. I might handle a couple of their chemo drugs, maybe. I might give that to them, and it's, like, sealed in a package that says do not handle at all, like, or if you're pregnant, don't handle, or, you know, all this other stuff, like, and you want to make sure that you don't, like, let it come into contact with anything else. But yeah, I couldn't break that down for you, honest to God, Free Radical. Like, me personally, I couldn't break that down for you because I don't treat it often. Like, I literally have never had a situation where I came into contact and with somebody who is radiated. No problem, Free Radical. It's just, like I said, certain specialties, like, handle certain things. Like, it's kind of like the reason, like, for instance, Skitch handles emergency medicine. So there's certain things that I do that he doesn't see often or deal with, so he doesn't know because that's just not something he deals with. And there's shit I don't deal with. Like, when they talk about motor vehicle accidents and stuff, and he was talking about, like, a ruptured spleen or whatnot, like, I'm not going to see that. That's not something I'm going to look for. That makes sense to him because he sees it more frequently, like, because he's in an ER. But I get people who I'm just stabilizing. So all I know is that, hey, they came in with shock, and, like, hey, they said that they have this, so I'm gonna treat this. Like, so I don't really have to assess the, like, symptom, like and do like a physical assessment to test for those certain things. The only thing I test for is things that I would expect to happen like while they were currently in my care, like as a post-operative thing or whatever. So it's just like different strokes for different folks, you know? Like everybody has like their specialty. Oncology is just not something I really deal with. It's kind of like what we were talking about earlier with like wedge pressures and Swan-Ganz catheters and you know stent placements and cabbages and like heart recoveries, whatnot. Like I don't do those like out in my like ICU. Like we have a hospital, like a sister hospital that does cardiac like ICU. Like they have a CCU and they do recover hearts and whatnot and do transplants and that's just their specialty. So I don't know too much about that. That's why some of this stuff I have to like learn, because it's expected for all of us to know all of it, even if it's not in our area, just because it's like all considered under the umbrella of critical care or whatever. So I don't know if that makes sense. That was a very long-winded explanation.
It makes sense. I think. Well, it makes sense.
It makes sense, I think. Let's see. All right. I'll memorize this chart later. I'm not going to put you guys through that. Here, we'll go ahead and go to this part.
Question number
Question 14. A patient presents with near syncope. His vital signs and assessment include a BP of 99/60, heart rate of 108, clear lungs, skin is cool and dry, veins in the neck are flat and dry, oral mucous membranes. A recheck of BP is 88/60, which is indicated for this patient.
So neck veins are flat, right? That's pretty bad for volume wise, right?
Yeah, they don't have like a lot of
On the right
volume.
track.
They're
I'd say
clear.
it's probably normal that your neck veins are flat. Your neck veins shouldn't be bulging out normally.
Yeah, but I think the main focus is like clear lungs, so they're clearly not wet. Veins are flat, cool and dry. So dry oral membranes, and then they're dropping their pressure.
Explain for the people in chat why the clear lungs means they're not wet and what that means in this
Mucous
context.
membranes should be wet. So if they're not wet, it
Correct.
means they're dry, which means they don't have fluid. It means they're vascularly dry usually.
The clear lungs.
And their lungs are clear, like, so, I mean, that's a normal finding, but like it just means that, hey, like they're not in fluid overload. Heart rate is elevated only because the blood pressure is low.
And why would you get abnormal lung sounds and fluid overload? What happens?
Because fluid backs up, like, into the lungs when you're in fluid overload.
So then you hear what?
You get wet, you get crackles.
Yeah, you get crack.
Snap, crackle, pop. Crispy.
Snap,
I know,
crackle, pop.
I was like, I know you know it, but now chat understands too.
Yeah.
Yay.
Graduate from
We're
Elgin
learning.
University. Only $5,000 for a diploma.
Oh my
Well,
god, $5,000.
Yeah, Ashley will sign it and mail it to you. Checks can be made out to Skitch.
Does it come with a sticker?
Everyone wants their sticker. Well, we're gonna
We'll get
go
you
with
a seal.
volume. I don't think we're gonna go straight to pressers. I don't think pressers is the problem here. So, preload.
I agree.
Yeah, we're gonna go with A. We want to increase our preload because we are volume depleted. Preload is measured by CVP. CVP is probably low. This person's
And then
dry,
if-
neck veins are flat, clear lungs. A.
What would it say for the neck veins? What's the opposite of them being flat? Like bulgy? And-
Bulging, which means they're overloaded, usually, or right-sided heart failure.
But what do they say in the clinical vignettes?
They'll say venous
Distension.
jugular distension, JVD.
Oh yeah. Okay.
Yeah, or they might honestly say like you can see bulging neck veins.
Yeah. All right, I do have to pee real quick, so hold on. I'm gonna hit play
14.
and let
A
it play through. I
patient
can still hear it
presents
though.
with near syncope. His vital
Okay,
signs
I
and
was gonna say,
assessment
I am
include
not.
a blood pressure of
Okay,
99
again.
over 60, heart rate of 108, clear lungs, skin is cool and dry,
That was a
neck
very
veins are
long time.
flat, and dry oral mucous membranes. A recheck of the blood pressure is 88 over 60, which is indicated for this patient. A. Volume expansion is needed to increase preload and increase myocardial stretch. B. Pressors are needed in order to increase afterload and increase myocardial stretch. C. Volume expansion is needed to decrease afterload and increase myocardial stretch. Or is it D. Pressors are needed to decrease preload and decrease myocardial stretch? And the answer here is A. Volume expansion is needed to increase preload and increase myocardial stretch. So this patient scenario is one of hypovolemia. Fluid administration is going to increase the preload, or it's going to fill up the tank, which will in turn improve the myocardial stretch. Since this patient is volume depleted, the systemic vascular resistance, or the SVR, is going to be high because vasoconstriction occurs as a compensatory response to maintain the arterial blood pressure. I know I've said this a million times, but pressors should not be used in the presence of hypovolemia. Your afterload is already going to be high, and what you need is fluid. This question does not give us hemodynamic values, but what it does give us is a good assessment that kind of in its own way gives us hemodynamic values. So it's telling us he has clear lungs, flat neck veins, and dry oral mucous membranes. That is not a sign of someone who is fluid overloaded. So sometimes you really just have to put all of these assessment findings together.
All right,
and
let's see.
think about it in the terms of your patient presentation.
Scared the crap out of me there, Ash.
14. Or-
Sorry. A patient is admitted complaining of crushing chest pain. Uh-oh. Began 2 hours ago. ST elevation. Oh, Lord.
Why are the questions getting longer?
Oliguria, and bilateral diffuse crackles. Okay, Which hemodynamic findings should be expected at this point? It's going to be elevated. So it's going to be A or B because of that. Cardiac output, I feel like, is going to be elevated. Wouldn't cardiac output be elevated? Because this would be... Sketch.
So,
A or B?
what's your thought process?
Thanks for the 100 bids, Dom.
It's A, easy.
Thought process is I'm looking at the pulmonary artery pressure because I'm thinking crackles. They said crackles.
Okay.
And I'm also thinking blood pressure is going to be on the lower side, so the 90 over 60 isn't going to be it. And the reason I'm saying that as well is because they're saying oliguria. They're not really peeing a lot at all, but then they also have crackles. So I'm looking at a higher PA pressure, looking at a lower BP. Systemic vascular resistance would be increased only because of the fact that it would be clamping down, I think, to compensate.
I guess the better question is, what kind of shock is this?
SVR should be expected to be
Cardiogenic?
high. Dr. Med, Dom.
Correct. Because you're having a STEMI, so
Yeah.
you develop left ventricular dysfunction, you get cardiogenic shock.
Cardiogenic
So-
shock usually means to drop. Your CO is going to be on the lower end.
Correct.
So it'd be A. It wouldn't be the 5 because cardiac output. Yeah, it would be A.
I don't understand the PA or the SVR too well, but if the PA is talking about like backup of fluid, then that would make sense for it to be A.
Yeah. This is where I'm going.
But your SVR, well, because your SVR shouldn't be low, but it also shouldn't be high.
Why wouldn't it be high?
Well, I guess it might be high.
Your blood pressure's low. Wouldn't its compensatory mechanism kick in to clamp?
I think yes, so. But then the body's being dumb because your heart already can't pump forward and it has to pump against a higher resistance. It can pump even less.
Yeah, but
So then you
that's
go
kind of
down
what
that
happens in
spiral.
cardiogenic shock, doesn't it?
I guess that's true, yeah. You know what? I think Dom is right. Go figure.
I'm right too. I picked A. Oh,
I
Dom.
love the backhanded compliment for Dom there.
SPR should be expected to be high. Dr. Med Dom. Stop it. Alright. We're
D,
going.
A blood pressure of over.
Oh, for the love of God, pick it
is
already. Jesus.
A, blood pressure of 80 over 50, cardiac output of 3.8, SVR of 2200, and a PA pressure of 40 over 24. So,
Dude. So cardiac index is the 2.5 to 3.5. Cardiac output, is that the 2 to 4, I think?
Cardiac
And then,
output.
or is it 4 to
is
6?
4 to 6.
4 to 6, okay. And the SVRs are usually 800 to 1200. PA pressure is 25 over 10. All right, here we go. And that finishes this section of shock and hemodynamics.
Oh my god.
It didn't even go over neurogenic. That's kind of funny. It didn't give a fuck about that. It cared about cardiogenic, hypovolemic, and septic. Wait, why'd you say, oh my god?
Because I'm tired and I didn't even directly do any of that. Shit's hard.
Dude, shit's no joke, man. And oh my god, never mind. I was so wrong. Skitch. Don't hate me.
Oh,
Hemodynamics has a
What?
part 2.
No. Oh. Oh. Oh.
Oh,
That's all I was
right.
like, oh, they didn't even cover neurogenic. Or like obstructive, they didn't cover any of that. I was like, oh, interesting. And then here we are with part 2. It's 30, it's less than the other one was, you know? Alright, thanks Dom for handling that. Dude, people are so fucking annoying. God damn it.
Wait, what happened?
I just read the comments. It's just someone like, hello, down here. Like, just came in being stupid.
Oh.
I'm like, it's either
Yeah,
like
people.
a child or just a very, very immature adult. I don't know. It's just obnoxious. Alright, so on to the next. Let's just knock it out, Skitch. Painful and all. Which of the following measurements are within normal limits?
I think it's D.
So CVP is
I
normal and
second
D.
that.
PAOP, hold on, give me a second. Let me just... I think it's on the higher end of normal, yeah. It's not going to be A or C.
Because I was like, CVP is less than 5, so automatically you eliminate A and B.
Yeah.
And then PAOP, I think you said is like 12 or something?
Thanks, Dom, for the 100 biddies.
Definitely D. Easy.
So I was like, yeah.
Yeah. We're doing it.
Didn't know the answer to this question. Again, I would highly recommend going over to Hemodynamics and Shock Part 1 because I will go through this information in a lot more detail and more in depth. Question number 2. Which hemodynamic profile is most consistent with distributive or anaphylactic shock? Is it A, a blood pressure of 75 over 50, CVP of 8, PAOP of 8, cardiac index of 2.5, SVR of 1500?
Pausing. Okay, so everything is low. In anaphylactic, everything drops. So, your SVR would be low. Your cardiac index would be on the lower end, which that's, I guess, right at the end of normal. CVP is low. Blood pressure is low. PAOP is not really that low. I mean, this one is more consistent. I think C. It's C.
So let's talk about anaphylactic shock. We know that it results in this extreme histamine release response. And this histamine release results in massive vasodilation, increased capillary permeability.
And then it goes back to this whole preload afterload cardiac output / cardiac index situation. So hypovolemic and hemorrhagic are like the same because they both deal with volume, so that's why they put them together. And anaphylactic being distributive, that's why they put those together.
Correct. And I mean, sepsis does also fall under distributive shock.
They're just not listing it because there's two parts to sepsis. There's the early stages and late stages.
Yeah.
And they're focusing on the early stages of septic shock for the
And
test
then
purposes.
obstructive also includes things like a massive PE as well. So this is saying tamponade, which is true. Cardiac tamponade would be obstructive shock, but also if you have a massive PE, that's also obstructive shock.
Your patient has an inferior wall MI and a right ventricular infarction. He develops right ventricular failure. Which of the following hemodynamic values would you anticipate with this patient? So right-sided heart failure. I'm just thinking of blood backing up to like the body. So your pulmonary artery pressure doesn't and your PaOP don't matter as much. Your CVP is going to be on the higher end. I'm thinking cardiogenic. Increase preload and increase afterload. Give me a second. Be decrease cardiac output, increase preload, increase afterload. It's not B. It's not. It's not A. C, I think, is the most consistent. We're talking about cardiogenic.
It is cardiogenic, but
It'd be 8 to 12.
it's right-sided, not left-sided.
So we are talking about just an elevated central venous pressure then.
Yeah, because your right side of the heart can't pump out, so you
Right.
still get a backup of it.
So, but for some reason, I thought I remembered on the chart that it would be an increased preload and afterload for cardiogenic. Or are they just focusing on the fact that this is right-sided?
I think they're mostly focusing on right-sided because I don't think you can really tell afterload based off the PaOP. I think it's just a difference of, are you seeing a high pressure on the left side as well? I think is what this question's getting at, which I don't particularly remember the difference between the PaOP and the PAP. So that's the part where I'm kind of confused on.
It's A.
Of 10 and CVP of
So normal.
So in
normal
this
and
scenario,
normal.
we have a patient with a right.
I mean, that one's slightly, only slightly elevated by
So
1.
we're
The
looking
PAP
for
is
the
like up
values
by
that are
1
associated with right
on
ventricular
like,
failure.
and then the
And if only
PAOP
the right
is
ventricle
normal,
is
CVP
failing,
high.
it's going to back up into the right atrium. And which one of these values tells us information about the right side of the heart? We're going to be looking at the right atrial pressure, and that is the CVP, which if it's failing, it's going to result in a backup of fluid, resulting in a high CVP. So we can
Shine.
definitely eliminate B in this scenario. Our PAOP is going to be is acutely failing. Question number.
Okay, which findings is most indicative of cardiogenic shock? And then it goes right back to it. It's not A, it's not B.
Fuck. Damn it.
D.
Yeah. That makes sense because it basically is the definition of cardiogenic shock.
Yeah.
D, a cardiac index less than and in cardiac low to be shock state. Question number 5.
A patient is admitted complaining of crushing chest pain, which began 2 hours ago. An EKG shows that ST elevations in leads V2 through V4, which is treated with a PCI procedure to the LAD, following which procedure the patient develops oliguria, bilateral diffuse crackles. This is...
We have this one already.
Yeah. So this is a cardiogenic one.
Left-sided cardiogenic.
So it's gonna be this one. Well, it's A or C. B, C? My brain is not wanting to work anymore.
I think what we
Systemic
said is that
cardiac
SVR
output would be low, and the SVR and the CVP would be high or high.
Correct.
So, I mean, but the cardiac output isn't. Well, I keep confusing cardiac output with cardiac index. Fuck me. That's my problem.
A patient is
All right,
admitted
I'm going with A.
crushing in procedure to procedure. The expected put of over 50.
Oh my god.
SVR. So ST elevation in leads V2 through V4. What kind of MI are we dealing with here? We are looking at an anterior infarction. And what kind of complications occur with cardiogenic shock? Shock will pump down PAOP lung. Question number 6.
The early warm stages of septic shock are characterized by no to A. Not B. D.
I think D makes sense. Yeah.
It's D.
Vasodilate your vessels. A
Okay. Oh yeah, so there's a chart for this, guys, that makes this so much easier. I'll have to show you guys it. It's so much easier than what they're making this be. Like, leads 1, 2, 3, and AVF. And then we have leads 1, 2, 3, 4, 5, 6. And you think of it in terms of big lie, which is LII, little I, LI, ass up all the time. So to determine what everything is, if you had, let me show you guys what I'm talking about and make it so much
We
easier.
Oh, we do say all, SAAALL, going down, but that works too. Your mnemonic.
Here we go. So this one, big lie, little lie, ass up all the time. That's how I do it. So if you have like a block, or you have like, if you have elevation in leads 2, 3, and AVF, you're looking at an inferior infarct. And like if you're looking, and this is where like it goes to the cardio, like the cardiac section, which we have not gone over yet, but like there is, like, that's the biggest one they always talk about. If you see ST elevation and leads 2, 3, and AVF, what kind of infarct am I? It's an inferior, and it's like, they focus on that one the most. And then here, let me pull it up. Big lie, little lie, ass up all the time. Okay. It's gonna give me something crazy. So, see, it looks like this. They call it big lie because it's L with 2 I's, so it's the bigger lie. And then little lie because it's L, I, and we don't really look at AVL. Usually we look at AVF, so like, or no, we look at AVL, AVF, we don't look at AVR, we say fuck AVR. So it's big lie, little lie, ass up because it starts here, anterior septal septal all the time, anterior lateral lateral. So that's like the acronym we use. And usually the first thing I do if I'm going to take the test is I write it out, because I'm not sitting here looking at ST elevations, because half the time if we're looking at a screen like in the hospital, none of those screens are going to detect an ST elevation unless it's like drastic, like you might see it on like your space labs or whatever. But other than that, the only way to check is to do a 12 lead, and that actually gives you like measurements and whatnot. So I'm not going to sit there and say I think someone's having an MI based off of like cardiac monitoring. Like I can see PVCs pretty clearly on that. I can tell if someone's an AFib or AFlutter, but like when it comes to like elevations and prolongation and whatnot, like that's something I would want an EKG to tell me. Oh damn, Diamati was in the hospital for pericarditis. Said a month ago.
Otherwise, I would highly recommend knowing.
Dude, I'm glad to see you're okay though, man. Did they say what happened or what they think caused it? Which of the following hemodynamic profile is indicative of hypovolemic shock? I'm not gonna lie, I don't know what it is. Skitch. Wouldn't it want to compensate with vascular resistance? For
Yes.
volume, for lack of volume, so wouldn't your SVR be more elevated?
Yes.
Okay. Well, at least I'm getting that correct. You don't have a lot of volume, so I wouldn't think your PaOP or PaP would be elevated. Right? So it's between B and C.
Correct. Or yeah, between B and C.
So am I going with C?
honestly, if you're hypovolemic, what's your normal? Or
There you go, it's C.
that's yeah.
Dude, as you could tell, I'm burning. I'm burning out, man. So hard right now.
You got this.
You know what would make you feel better, Ashley?
I already know what you're gonna say.
Marvel Rivals.
Ooh, curveball.
The following hemodynamic profile has been obtained for a patient with a blood pressure of 112/60 with a RAP of 3 and a P8. An RAP?
Right atrial pressure, I'm assuming, is what that means. Which would be pretty much the same thing as the
Same as CVP. Okay. Pulmonary artery. They're just abbreviating this different. 44/24 PaOP of an SVR. Elevated with the with the cardiac output or index, it's low. Okay. I mean, yeah, I guess they could have some left-sided heart failure. It's not a volume thing, no. Seems to have sepsis, no. B and C are not correct. Patient has developed ARDS. I don't know where you'd be getting that from. I mean, evidence of left ventricular failure could be a thing. It's backing up. That's what it is. Okay. Which of the following hemodynamic profiles would best exemplify that seen in early septic shock? Okay. So we're gonna clamp. No, we're not. No, we're not. Hold on. Jesus. Dude, I don't know. I'm now my mind's breaking now. Sketch. I mean, I don't think it clamps because I remember SVR clamping on hypovolemic shock because it had to. But septic shock, I think it dilates. Or not, you know what I mean. And you need fluid, which is why they give you fluid. I don't think all of it's low, though. Anaphylactic is when all of them are low.
Well, your SVR would definitely be low, I think, for sepsis.
So D.
I think so, yeah. I think that
Said
makes better sense.
rest. Yeah, I think it's time to call it, dude. I don't even think I can finish this. It's starting to really fuck with me. I'm not gonna lie. I
Well,
think I
you'd
need
feel
to.
better if you went to Disneyland.
Yeah. Everybody who's watched this far, like my energy has hit the fucking bucket. So I appreciate you guys for even putting up with it this long. Thank you for watching, everybody. I hope you enjoyed or learned something. I would have explained more towards the end, but I literally was just trying to get these test questions out of the way. So, yeah. Charles the Red, thanks. I should have said something an hour ago. Yeah, dude, I fell off this last bit. I couldn't, yeah. Googling acronyms, learned a lot. Yeah, no, I will do better to explain more on the other one and make sure that I'm not as tired when I'm trying to do this, because clearly that's just a lot. But yeah, thanks for hanging out, everybody. I hope you all enjoyed. I will be back on tomorrow, so I will see you all then. Or I guess later today, whatever you want to look at it, because it's like 1:42 in the morning. Bye, guys.